There we go. Recording in progress. All right. This meeting's called to order. Good morning. Welcome to the 2025 PEB Board Retreat. Our meetings are going to continue to be hybrid. HCA staff will be on site. Board members and other attendees have the option of attending in person or via Zoom. For our Zoom attendees, our opening slide is information about how you can turn on closed captioning subtitles. Dave, you want to kick us off?
Yes, good morning, Chair McDermott, members of the board. I wanted to start the meeting acknowledging something that happened at our board meeting for the SEB board last Thursday and how it's impacting how we're managing our meeting. Especially, I want the public to be aware, the members of the public who are attending right now, if they haven't noticed or seen the shift, the slight shift, but an important shift that we're making. So there was a deeply troubling incident that occurred last Thursday at the SEB board meeting. And I want to express the agency and my sincere regret and frustration that this happened. HCA recognized that the experience was distressing for everyone present, both personally and virtually, and everyone experienced the event differently, and we are deeply sorry for the harm that it caused. So briefly, during the meeting, an external entity that claimed to be associated with the Chinese Communist Party hijacked the Zoom platform, taking over audio and video capabilities, and for about 35 seconds, the hijacker broadcasted profanity, CGI pornography, hate speech, including racist remarks. And while we do not believe the attack was targeted at specific individuals, we recognize the significant impact that it had on those who were in attendance, and the agency does not find this type of behavior acceptable, and it's appalling. So going forward, we are implementing enhanced security measures, and one of those is using the Zoom webinar format. And so this will be a different experience for both members of the public and a little bit for the board. The members of the public will only be granted audio and visual permissions when they raise their hand during a designated public comment period. That's either while there's a discussion, a call for public comment on a specific resolution, when we have those activities in a board meeting, or at the general public comment period at the end of the meeting. Otherwise, throughout the meeting, the public will not see any functionality that allows them to unmute themselves or turn on their cameras. And our typical mode of operation is that the chat functions are generally disabled during the meeting as well, and that will continue going forward. So if you're a member of the public right now and you're looking for your mute button or your camera button, you're not going to find it, you won't see it. When we do a call for public comment, we'll ask you to virtually raise your hand, and then you will be given temporary permissions to turn on your camera, turn on your microphone. We will stand ready that we know that this happens some throughout state government, that if somebody in that instance that we don't know who they are starts to do something that is inappropriate, like happened last week, then they will just simply be, those permissions will be immediately removed, and we'll proceed with the meeting. So the agency is committed to ensuring a safe and respectful environment for all participants. We do take the situation very seriously, and we want to thank you for your patience and understanding as we address these challenges and implement changes to improve the safety and security of our meetings. So thank you, Chair McDermott, for letting me start the meeting a little bit off of that.
Absolutely, and I really do appreciate we had a quick turnaround during the meeting where we switched over that functionality so that wouldn't happen during the meeting, and now we're using it in subsequent board meetings. So we had IT staff down here, PEB and SEB staff, everybody worked on it and got it switched over, but we did have 45 seconds of chaos.
35.
We had 35 seconds of chaos. Let the record stand corrected.
A long 35 seconds, let me tell you. And it doesn't matter really how long it was. I only say that because most people felt that it lasted 2 or 3 minutes. The damage is done whether it's 15 seconds or 3 minutes, but it was about 35 seconds.
So I appreciate all the work that went into that. Good. All right, let's go ahead and do roll call. Elliot.
Chairman, we're still working. Jessica's reaching out to her right now.
Okay. Elliot is not available yet. Makayla.
Present.
Sharon.
Present.
Kurt.
Present.
Harry.
I'm here, thank you.
John.
Present.
And Tom.
Will be Jessica's next call.
Tom is Jessica's next call. I see. And Michael Tunick from the AG's office. Present. And I'm Lou McDermott. I am the deputy here at HCA, and I'll be filling in for Mary Ann Linda Glad, who is the interim director. Sue Birch's last day was January 15th as the new administration came in, and Marianne has been doing interim. For folks that don't know her, it's a little bit of a legend around here. She's one of the few people in the country who has run the Medicaid program, the PEB program, and behavioral health program, which is what we have here at HCA. Seb wasn't around when she was back there. I'm sure she would have led that as well. So Marianne has come in with a steady hand in getting us through, with transitions to new administrations at the federal level, at the local level, and throw a 105-day legislative season on it with some unprecedented budget shortfalls. We're very happy she's here, and she'll be joining us shortly. With board members attending both virtually and in person, it's going to be really helpful for the board to hold their questions until the presentation is done, or if the presenter pauses and asks for questions. There's going to be one resolution scheduled for action today, and the public is going to have an opportunity to provide comments on the resolution during normal procedure before the board votes. The public is also going to be able to provide general comments at the end of the meeting during the public comment period. And as a reminder for the public, if you have questions during the presentations, there's going to be an email address for the presenter, and you can go ahead and send an email and ask your questions at that time. Dave, you want to go over today's agenda?
Absolutely. Today, with the retreat, one of the parts that signals it's a retreat is first, it's a longer meeting. It's all day, and the rest of our meetings tend to be about half days. But part of our retreat format is to have some sort of educational panel discussion topic. And this year, we thought, given the volume of network terminations letters that members get throughout the year, that has become a more regular phenomenon, that it would be good to talk about provider network, have a provider network contracting panel discussion. So we're going to have that started off with Jean Bowie leading that. Then we're going to start leaning into some of the, what I call the past, present, and future. We'll go back into open enrollment, and we'll go into the legislative session and then talk about some future actions. But we'll kick it off with the presentation from the OFM Interim Budget Director, Robin Williams, to help the board understand the snapshot of the budget challenges that the legislature and governor's office are facing as a helpful context for many of the questions that we get throughout the year about how to enhance benefits. And that's going to be a very hard and challenging conversation to have, if not impossible, in the context of the budget update that Robin provides. Then we'll go talk about open enrollment. Over our working lunch, we will go through where we are on trying to continue to stabilize the benefits 24/7 system. We'll have a legislative update on where bills are in the first 2 weeks of the process, as well as a budget overview of Governor Inslee's proposed budget. Then, unusually, we very rarely bring a resolution at the board retreat or ask the board to take action on the same day that a resolution is introduced. There's a couple of rare circumstances, and they kind of came together for this resolution. It's related to the implementation of the UMP transition to Medicare Part D coverage, and it piggybacks off of a similar resolution that the board passed last year. But as we were implementing, there was a decision that needed to be made, and we wanted to get it codified as quickly as possible this board season. So we'll go through that with Stella. I'll review pinch hitting for John Parton today and reviewing the benefits planning cycle. We usually have a discussion about that at the retreat each year. We had an employee engagement survey that was held last summer, and our staff member Missy Yates will reveal the results and what we learned from that. And then it wouldn't be a PEB board meeting if we didn't have a Medicare presentation. And Laura Ryan, not Ellen Wolfhagen, is here to talk about that transition and how it went. And then I'll just do a quick preview of the rest of the board season. 2 quick reminders: if we have an emergency that requires us to leave the building, then we will purposefully walk across the street into the visitor parking lot. And if you need restrooms, head down the hall. If you see elevators, look to your left.
Awesome, thank you. And one quick note, I do have a call. Our septic system went a little bananas, so the guy is going to call me to get the okay to do whatever he's going to do. So I'll have to step out for a minute, maybe during the call. No, not this building. No, just at my house in the middle of a project that we're doing. So, home ownership. First presentation is going to be provider networks discussion. It's a panel discussion. Jean Bowie, the Deputy Director of the IRB Division, is going to lead it off. Would you like to introduce your guests?
Absolutely. Thank you, Chair McDermott.
With us today, we have Denise Corcoran from Regents and Ty Terry from Kaiser. Would you like to, just want to start us off with the
Sure, happy to. Good morning, everybody. My name is Denise Corcoran. I'm Vice President of Contracting at Regents Blue Shield in Washington. I have oversight for the network contracting for our Blue Plan and also our plan east of the Cascades Assurance Northwest.
Ty?
Hello, I am Ty Terry. I am the Director of Provider Contracting at Kaiser Permanente in Washington. I have oversight of the provider contracting functions statewide and think of those as all contracts that are not tied to Kaiser Permanente medical facilities. So I have direct oversight of those contracts where we use outside medical facilities and medical staff and practices for our membership.
Just rolling here. So provider contracting includes multifaceted negotiations with often competing objectives. These include reimbursement rates, administrative burden.
Gene, 1 second. I think we have a
We're confirming if that's Tom and Robert before admitting them as a panelist.
Makes sense to me. Okay.
While there have always been contentious negotiations, it seems the frequency of mass termination notifications has increased over the last several years. We'd like to get your insights and perspectives on the provider contract landscape, the changes in the dynamics post-COVID, and ways to insulate members from termination notices, particularly those of the normal negotiation strategy, and new developments in provider contracting, including alternative payment methodologies, value-based reimbursements, etc., that might be impacting the frequency of these termination notices in the future. So I will ask a series of questions and ask for your feedback on this topic. So to start us off, how are provider contracts generally staged and what is their timing?
Hi, I'm happy to kick us off if that's okay with you. So typically, our provider contracts for the most part are what we call evergreen. And it doesn't just refer to Washington State. This is an industry term that we use. That means they auto-renew. It's basically just an auto-renewal. And occasionally we have what we call hard end dates or hard terms where we know that a contract is ending and at a certain period before that we will start to negotiate. What we've seen lately is even with our larger systems that might be on evergreen contracts is they're issuing termination notices to open up those negotiations. They often seem to fall on the first of the year, but not all contracts renew at the first of the year. Typically, we try to stage them out from a health plan perspective, just from a resource, constraints and lifts. So we try to work with the health system or the provider to understand what might fit for them in their, calendar, their fiscal and financial calendar, and then what we can do on our side to avoid that 1-1. It's not great. We also have accounts renewing at the same time. It's a very busy time of year at the health plan. So we do try to stage it out that way. But also a lot of the hospitals will come to us and say, hey, our fiscal year actually aligns with CMS. Can we do a 10-1 renewal? Can we do something else? And so that is a negotiation point oftentimes in a contract. We typically try to do multi-year, right? No one likes to be at the table perpetually. You don't seem to get much accomplished if you're only renewing the agreements every year. We can stage a multi-year term. We can work on other things, other partnership opportunities throughout that term and not have to worry about renewing that financially.
Hi.
Yeah, so I would agree with virtually everything that was just said. The timing of contract renewals is often dictated by the fiscal year of the facility or the system that we're working with. But it is definitely a point of of the negotiation, right? The effective date and the term notice. We also strive to have evergreen agreements so that we are not perpetually at the table. And, that some systems and groups will use leverage of the termination and the specter of a looming end date, right, to their advantage. But it's also understandable too that sometimes without that, things can go indefinite, and that's not necessarily anyone's intention. But it's an understandable leverage point. So that's not anything that we want to be the major cause of disruption to the network. We always try to manage that through ongoing discussions and relationships throughout the year. So we're not only talking with these groups and partners at the time of renewal negotiation. So we really strive that those things are never a surprise, and that we can forestall and forego any contentious public involvement in the negotiation or discussion about a termination, because we never want to have members put in the middle of this process.
Can you talk a little bit about the dynamics that negotiations have, how they have changed since COVID?
I would, if you want, I'll start on that one. What I would say, what's changed since COVID, everyone without exception experienced that event in our businesses and our practices changed, some for the better, right? But I think in terms of financial position, it has put a lot of facilities, practices, and health plans in some financial peril. So it's made the stakes for each negotiation perhaps that much higher. And it increases the need for us to engage directly in deeper discussions about the relationship and how can we advance more to those alternate payment models and value-based relationships with even more urgency than we had before the pandemic.
Yeah, I will add that a lot of the dynamics of negotiating have changed since the pandemic. We know that hospitals were on the front lines, and no one would deny that they faced unprecedented times. The first case was here up in Kirkland. They had to act very quickly and pivot a lot of their resources from performing services that made, elective services that drew them higher margins than urgent. What has happened now since then is we typically see that providers and hospital systems are coming to us for larger increases than we've ever seen before. It's not out of the norm now to get a very high double-digit ask for a one-year contract. I think my counterpart here last week spoke about that. That's not something that we've typically ever seen in the past. We usually follow lines of cost of living adjustments or smaller trend increases. We do understand the cost of goods and services go up, but 70-80% increases in 1 year is just not something that our customers can sustain. It goes right down to the premium dollar. We have to, we pass on those costs of those services in the premiums, and members will have to pay higher out of pocket if they have a cost share. That's a percentage of reimbursement based, or their just overall premium will go up. So we're fighting to try to keep it affordable, while still recognizing that hospitals are necessary in our community. They do provide services that are needed, but we have to try to find a balance there. Value-based works really well. A lot of hospitals and provider groups are willing to do what I call put your money where your mouth is. If they're higher quality, they're able to do care more efficiently and effectively. They should be rewarded for that. And what we've seen now is hospitals and systems are very focused on getting that top line revenue. They want that unit cost increase. They don't want to wait for that payment. Value-based payments often require a look back of performance and may sometimes be, 9 to 12 months out for that payment. And they can't really wait. So we've been trying to work with them on value-based, but also recognizing that they do need some money up front. We've seen slightly more aggressive tactics, as we spoke about in the previous question, more termination notices. Providers are often willing to threaten put members in the middle. They know that that's a point of leverage for them in a negotiation. It's very rare that payer, I don't think I've ever been at one in my career, has issued a termination notice first ever to open a negotiation. So it's definitely a tactic that is used by our providers and hospitals just to have that member leverage. And it's unfortunate. We try to avoid that by starting renewals earlier than we ever have. It used to be 6 months. We would work on them. We'd exchange proposals, and we'd pretty much come to a deal right before that renewal time. Now we're looking about 12 months out, starting those conversations, laying the groundwork, and then also issuing some proposals first. This is where we see us in the market. This is where we see you. This is what we think we can do together. It has helped some. Some don't want to engage that way, but it has helped.
Real quick, I just want to acknowledge a piece of what Denise just said and tie it together for how the member is impacted. Very rare. One of the things that people like about our portfolio of benefits is the breadth of the network. And very rarely would someone in our membership be complacent or excited about changing providers or losing a large facility within the network. And at the same time, there's this constant vigilance on premium. And there is a direct relationship between having that broad network and premium pieces. So, as Denise and Ty were describing, very large increases that come, there's a point where the membership rightfully demands or wants certain facilities and large providers in the network, and there is a trickle over, or not even a trickle, sometimes it's a large part of the premium increase is related to maintaining that broad network. So just wanted to tie those two concepts together, because many times we will hear keep the premiums low but have everybody in the network at the same time. They aren't diametrically opposed. There is a relationship between those concepts.
And I just got word we have a couple of board members who just joined us. Elliot, are you with us?
Yes, I am.
Excellent. Good to have you. And Tom? We can see you and we know you're talking, so we will acknowledge that you are here. Oh, there you go.
How about now?
Perfect. Good to have you, sir.
Thank you.
And we have a question.
Yeah, can I ask to dig deeper in that? Because one of the things that I hear from like a lot of our state employees is specifically around preventative care, but like the idea of like licensed massage therapists, for example, or acupuncturists, where there aren't enough people available. So when they're looking for someone, like the network isn't broad enough. And what I hear you saying is, if we were to add more licensed massage therapists to the network, that might up the premiums.
I guess I hadn't really been thinking of the question in the context of specialists, so I'd be curious, Ty and Denise's insights about kind of the specialist part of that work. What my remarks that I was making earlier were a little bit more about the large hospital systems either being in or out. And I think we're doing a really good job, and did a really good job last week of nobody identifying any specific provider, so I won't go further, but if a large hospital system has a high volume of claims within, for example, the UMP, then whether they're in or out of network can have a profound impact on premium.
Okay.
But I'd be curious to hear the perspective about specialists. Denise turned on her mic first.
Sure. So short answer, yes. And that's because as utilization increases, it will directly will tie back to premium. But also, what I've noticed here is, especially in specialists and then your ancillary providers, they oftentimes don't take insurance. And it's a whole host of reasons. A lot of it has to do with administrative. They're oftentimes smaller practices. They may have only one or two people on staff, and they can't do the administrative work. And I understand it. We are administratively complex industry, but also they private pay or out of pocket, their reimbursement is higher in their scoops in general. We often can't meet what they can charge out of pocket from a reimbursement perspective. If we were to meet it, then yes, all of the costs would rise.
They just have one. And I mean, for what it's worth, I think at least in talking, and I realize like my sample size is not broad across like all of state government, but the of the people that we're talking to and of the providers, like the feedback just to share with both of you is that there are many people who have the benefit that want to use it and don't feel like there are enough people. So like I get that like the more you use it, the more premiums will go up, but there's got to be a leverage point of like, and it's got to be available enough. And talking to local massage therapists or acupuncturists, they're saying we're trying to get on, but it's the access to become a part of the network is the worker. So I get like small businesses and like administrative costs and all of that, but that's not the story that we're hearing.
Thank you.
I guess I have a question related to that. How do you determine if there's enough? What sort of metrics do you look at to say there's enough access? Because I think from your side of the table, it might be difficult to understand sort of the bandwidth and to say, we're seeing certain amount of utilization, but is it because their individual panels are full and they're not taking additional patients, or other reasons, or they do have the bandwidth, therefore there is capacity within the existing network?
And that's a great question. So it's very hard for a health plan to tell specifically access. We rely on providers to self-report that information. We do collect it, and open panel, closed panel, it's part of our directory, but it's only as reliable as the data that we get. We do know that as an industry, there are long waits for certain specialties. Endocrinology, dermatology is always at the top of the list, and that is a nationwide issue. We do offer surveys. We have a provider relations team that again tries to remain in contact with the practices, collect this information, bring it back to the plan, and then report it out in some fashion. For adequacy, we have state and federal requirements depending on the product line, but just because you have that count, it's very numbers driven, right? It's the count of providers for Medicare, it's just time and distance, it's just numbers driven for the state. So that doesn't tell you that someone's taking patients or actually, seeing patients. So that's why we have that extra measure of trying to collect and report on that data that's reported back to us from the provider offices.
I want to imagine too, from your call centers, you're probably getting information from your call centers when people call and say, I'm having trouble finding XYZ.
Yeah, we do. And that's all logged. We have a customer, most health plans have a customer, a customer module that tracks and logs all the calls. They're also recorded. And we have a team within our customer experience shop that helps members find care. So if they call and they say that they're not able to, they've been trying so-and-so, we do have specific reps that will then also try to make outbound calls to provider offices and then link the patient to try, or the member to try to get them in.
Thank you.
And I'll let Ty respond because your plans might have some specific requirements as well.
Largely, it is this similar process in terms of how do we measure accessibility and network adequacy. We rely on surveys and on metrics provided by regulatory requirements, and also industry requirements for specialty access. And largely, we have the same member experience team, and also our provider experience team will do outbound surveys to measure access and availability as well.
Can you tell us what impacts pricing transparency has had on network relationships and rate expectations?
This is my favorite topic. And I spoke about this last week as well. And so, in my opinion, and there are also several articles out there, I think in theory, right? So, price transparency is a mandate that both providers, hospitals included, and payers have to post their reimbursement rates. And the thought behind it was consumers would go out and price shop and see who's more cost competitive, and thereby direct their care to the facilities or providers that are more cost competitive, thereby driving volume and helping prices to come down. Well, what we've actually seen in my experience, especially in negotiating contracts, is the exact opposite. And I think it's because there's not that much compliance with the bill, especially from the hospital side. And also, it's confusing for consumers. I don't think the information is straightforward. It's very hard to actually find the service you want and look at these tables. They're machine readable files. You have to have software to download them. Like it's not super consumer friendly. What we've seen is actually providers and hospitals using this as a negotiation tactic to say, hey, I'm not reimbursed as much as so-and-so for maternity. I want you to increase my rates to match XYZ hospital. And it has actually driven prices up. It feels like it's more of a race to the top. I don't ever see a provider coming to me saying like, hey, I want to be more cost competitive. Give me the lowest rates you have in your network. It's actually the opposite.
That'd be a quick negotiation.
Yeah, like,
You're like, deal.
yeah, right. They cite parity. They want parity amongst their peers, amongst payers, which is really not the economic model or the business model behind how we reimburse, right? We bring volume to the provider, and that volume should drive down the cost. And they're using this transparency data to frame arguments that they deserve to be reimbursed as some of their higher cost peers. I'll turn it over to Ty.
Yeah, again, I would agree with that as well. That it was a well-intentioned initiative, but I don't think it has had nearly the impact that was intended. And I think my experience is that most members, consumers, they really do not want to be involved in that transaction discussion. Even with all of our efforts for consumer awareness and education, it has not had the effect. And largely it's because we've done our job well from a benefits construction standpoint and administration standpoint, is to take the member out of the middle of those transactions, and that's why we exist. And I think we've taught the public to not want to be involved or interested in those discussions. And it has not really helped to pull down costs at all. And again, to my counterpart's point, it has done the opposite, where we may be striving to have deals that do drive volume to particular partner groups or facilities because of that commitment to volume. When you have the parity pressure of, well, I must have the same price as someone else. Well, they're not doing the same thing for the network that our preferred partner may be doing. And so the price is not something that should come into the equation in all instances. So, no one asked for my opinion about how could this be better, but, I always find it concerning when we conflate cost and price. Price is very simply the price someone is charging. It is not anywhere related to the actual cost. And I think that's where maybe more focus should go to make sure costs are really evaluated in a transparent way rather than price, because the price is somewhat an arbitrary measure.
I'll just add to the discussion. Consumers focus on a lot of things outside of pricing costs as well, a lot of soft factors. I've experienced this with our membership where we'll talk about what the cost of something is and where they can go and present them with information about readmission rates after an outpatient procedure or infection rates. And they'll say, but I want to go to the one that's closest to my home because when I'm admitted overnight, then I'll have family that are more likely to visit me. That's a completely valid part of the equation. Or they say, I want to support my community hospital. That's what I want to do. I don't want to go to another part of the state, even if you tell me that it could have a better outcome. It's about supporting their community. And so there are a lot of other factors that go into this.
I think one of the big ones too is referral patterns. I think your doctor is a very trusted individual. They know all your sort of secrets, and then when they say you need to go over there to have that done, it's very hard for patients to be like, I think I'm going to go to this other place. That's not what their doc is advising them to do.
Why does it seem that more negotiations are becoming public discourses and more termination threats?
I think we alluded to this a little bit earlier about the leverage that providers have by utilizing the termination notice in their contracts. We also see them going out sometimes in the public earlier than the plan will, which to get to kind of start to control the narrative and get the sympathy on their side from the public. It's very causes a lot of stress for a person when they find out their hospital that they use, if they are sick, that getting hospital care, or even just their primary care, their PCP, who maybe they've been seeing for years, will be out of network. And providers know that. They know this, and they definitely use that to their advantage. At the plan side, we have an obligation to notify members if we are approaching termination within 30 days. We have to notify members of that they could be eligible for continuity. We have to supply them with a number to call in to see and to elect continuity of care if they are currently receiving qualified services. That continuity of care runs from the date of the notice. So we typically don't go out any earlier than we have to preserve that timeline for members' continuity of care. It's for us, it's unfortunate when a provider chooses to go public first and put that stress out to the public and that anxiety onto the member before we even really have to, and while we still have time to come to an agreement.
I would agree with, again, all that was said. It's never helpful, in my opinion, to put the members in the middle, because again, that's why we exist as an industry, is to remove that burden away from the member. And we know that they rely on the security of the network that they've chosen and that we've provided for them to be solid and to be consistent. And nobody signed up for a lot of disruption. So it is troubling when another entity will make the members, pawns in that game. So again, what we really try to do is to focus on the relationship development with that partner to make sure that we are having those open conversations about all things: administrative burden, pricing, workflow, claims times, all of those things we want to be bringing into the equation before we are at a negotiation. so that we don't get to the place where we're having a public discourse or a public discourse about it, and airing that in the public. So I'm actually, I think we have a really good track record for avoiding that. And when we can't avoid it, we absolutely regret it, because that's never, ever our intention.
You have a question?
And I'll preface this by saying I don't think this is isolated to the insurance industry. Like working in government, we very much feel it too. But just kind of wanted to add the point of context to it. I just think, based off of your initial question, Jean, there's just a general distrust that's happening about the insurance industry, about government, about like all these different industries, and kind of the antidote, which we think is of what we're asking for, is, well, we need more transparency. But then the issue is that you give transparency but no context. And I'm not saying you, I mean, say like all of us, like we give transparency and no context, and then people feel even more confused, because it's like, I have all this information, but I don't know what to make of it. But the end result is I'm paying into an insurance model, or I'm paying taxes to my government, or I'm paying into this thing, and I don't feel like I'm getting what my value out of it. I don't feel like I'm getting what it's worth. And so it's like, I don't know what the answer is, but I do think that the negotiation or what's happening is not the root of the problem. I think the root of the problem is that people are feeling this sense of distrust because they're not feeling like they're getting the value out of what they're paying.
I think you're absolutely right with that. I think everybody feels that if they're not getting the value of what they know they're paying for, impacting their budget, it's valid to ask those questions. And it is every industry. We're not immune to that. And we are also probably one of the least loved industries in the spectrum. So that's another thing that we as was said, there's information without context. We are very much a data-driven industry, and we have a lot of it, and it's complex. And so I have a saying, I don't know how many people appreciate it, but we can explain it, but we can't understand it for you. So we need to get better at that, and that's something that we need to strive for.
It's a really, really well articulated comment. And I would say it's usually one that drives our negotiation. Because, can I ask, do you think it's gotten better over the past 5, 7, 12 years? Probably not, right? But yet we keep and listen, I'm not here to bash anyone side of the fence, but we do keep raising reimbursement rates, and it's not getting better. So at the end of the day, I have to ask my counterparts at the hospital systems, frankly, what am I paying you for if my members don't have access? We can't get timeliness to care, like you brought that up too. We hear it on the phone lines, and we're not sure, or it's very hard to see the quality but we don't see the tide of the cost decreasing at all.
I'll just one comment about that. I mean, I do think there are many situations where excellent care is being provided, excellent protocols. My wife recently had a knee replacement in November, and we went to a facility up north, and we got amazing care. The physician, the surgeon called us that evening. All the things that were supposed to happen happened. And that's one of the tough things is once you get in the pipe with the provider and you're going down a path, it's hard to know what type of quality you're going to get until you get it. And then sometimes you walk out of there and go, that was amazing and that was awesome. Sometimes it was adequate. Sometimes it's terrible. And it's very difficult to know that with the information out there. Cost transparency is great, but quality transparency is not there.
Do you have some thoughts on what more can be done to protect members and keep them out of the middle? Ty, do you want to kick us off on this one?
I want to make sure I heard that question.
Sure. Are there other strategies or more that can be done to keep members out of the middle in these negotiation situations?
There probably is more. When I think about how we try to approach it, like I've said previously, we really try to work it on a relational level and make it less of a transactional issue. Of course, everything does need to be driven by, can we fund the care that we're being asked to provide? And that is, of course, central to it. But there's always more to it than that, right? So those discussions have to be from the outset more than just what is the price or the cost, but what are the other elements of our relationship that we can work on to make our mutual journey better. If we can't always come to agreement on a price, what can we do otherwise to meet the needs of each other's organization, all for the mutual benefit of the patients and members that we serve. So is there more to be done? I think it in many ways is sometimes a top-down approach, right? From leaders of health systems and medical groups, and also leaders of health plans and insurance companies, of how do we really deepen the relationships with each other so that we are not competing with each other for the dollars, right? But we have the shared mission to care for the members and patients in our charge. And the thing is, there is enough to go around, right? And if we can understand that we want to have everyone succeed, especially our patients and members, then we will all succeed in what we're doing as well, and there will be enough to go around. So I think it is a top-down approach from the perspective on what we're willing to give and give up for a successful relationship.
I would completely agree. I really liked what you said about making sure that both sides are keeping the member, the patient, at the forefront of the conversation. It's very true. I think it's helpful when both parties, if we are running into the time frame or the deadlines, where we do have to start notifying that we're aligned in messaging, and also time frame for messaging, and making sure that we're avoiding confusion in the market, not messaging something different than either, than the other one, and helping the member to understand what's actually happening, and what they have the right in the event of termination.
The other piece that I'll add is what the experience of the last couple of years is when public notice of a termination goes out, there's a lot of engagement of our PEB and SEB members with the healthcare authority. And we have tried to work on the consistency of our message. But I think it's something important to highlight here is that HCA isn't in the room in those negotiations. And to put a very fine point on it is, like, we pay our carriers at our TPA that is part of the services that we pay them to do, for them to manage that process. So we try to help the members understand kind of the nature of these negotiations. We try never to guarantee any outcomes, though the vast majority of time, there's an 11th hour agreement, or hopefully a week before the 11th hour, but there are way more instances than not, where an actual agreement is ultimately reached. We try to reassure people that that's a very likely outcome without promising that it is. and that we're always monitoring the situation throughout the year. As Denise and I said, the nature of the provider negotiations is that there's always a negotiation going on with somebody at some point, which is why our members have seen notices sometimes in March, sometimes in April, sometimes in October, sometimes in January. It's kind of a rolling process, and we have a cadence where all of our partners keep us apprised of where some of the larger contracts are in movement with some of the biggest systems and provider groups. And that when there is something that's gone into public termination, there is a very specific cadence that we all follow to kind of keep HCA informed, with usually both sides of the table to help. Sometimes we end up in this, not a true mediation role, but a communication shuttle of like, oh, I'm hearing this, help me understand this. It seems like there's a breakdown here. And sometimes Sue and I, and in the future, Mary Ann, and then our next director will say, hey, we're hearing both sides say something that's completely opposite. That, there is a clear communication breakdown. Those two statements we've heard can't be true. So why don't you start there? And we've been able to help break a log jam periodically just from a simple miscommunication of parties that are happening. So I say that all to remind and highlight for everyone that HSA isn't in the room, but we have a very clear, important stake in the outcome, and why we aren't in the room, but how we kind of help monitor the situation, especially as some of the negotiations do start to reach that 11th hour actual termination possibility.
We touched on this a little earlier, but what innovations, such as alternative payment methodologies, prior auth approaches, administrative simplification, can and will take place, and to what extent can these help protect members?
I can start. So I'll pick up on the administration simplification component of that question. And we know at the health plan that prior authorization is important. It ensures that our members are getting the right care at the right time, in the right setting, and protects our members from unnecessary or avoidable treatments. But we also do recognize that it's a step in a process that can be burdensome for our provider community who are trying to act quickly and trying to do the right thing. So we've done a few things in this space. We've introduced something called Smart Off into the market. Our longtime partner with this technology tool has been Multicare. They've had a lot of success with it. It is an app that embeds right into providers' workflow in their EMR, and it has all of our prior auth requirements, and it's updated real time. The provider puts in the procedures that they're looking to do. They put in the necessary documentation. The app will check the medical record, do what it needs to do. I'm not clinical, and it render a decision much sooner than heaven forbid we still use fax machines, but we do. We're like the one industry that still does. So embarrassing. But yeah, but it's much, obviously, right? Much quicker. And we know that our friends at Multicare have been able to increase productivity by 140% to 233%. So depending on the case, it's been really helpful. We've participated, regions, in several work groups at state level, addressing administrative simplification, also looking at healthcare quality. So this is something we're very focused on. We do have requirements at the plan level to protect members, and this is some of our process around that, but we are also looking at making it, how can we do it better? How can we work with our providers to do it better? And just a little bit on the APM front. So alternative payment models. I'm from the East Coast, if you couldn't already hear it by the way I speak. And we've been doing risk and risk sharing, for a long time there. And I believe that when providers have what we call quote unquote skin in the game, it lends for a different and better conversation. You do tend to not get in that termination, that transactional kind of relationship conversation, but more of like, how can we take care of this population together better? And we slowly, this whole team of us at Regions have been slowly working on what we're offering in the space to our providers in the market to participate in some type of total cost of care sharing, moving the needle, helping us take care of populations. And it is not a quick uptake. It requires a complete kind of change frame of mind. But working with certain practices and health systems, we've really seen an improvement in the total cost of care, and we continue to improve in this space. We're also looking at launching. We had in the past what we called episode-based care reimbursement, so reimbursing a provider for an entire episode of treatment, not just on that one service. We are looking at revamping and coming to market with more opportunities in the space in ortho and in cardiology. So looking forward to seeing how we can continue to deepen our partnerships with our providers to, again, avoid that transactional conversation.
From our perspective, very similar. We want to try to attack the administrative simplification through a digital first drive. Right, everything that we can convert over to an electronic format, we want to try to do that. And yes, still use the fax machine because sometimes that is the handiest and fastest way to get it done safely, given many of the online risks that exist that we have to encrypt things. So sometimes the fax is still the most secure form. That said, the movement to more value-based discussions and alternative payment methodologies, as I said earlier, that has been given some additional fuel from being in the post-pandemic space, and due to some of the larger than expected or larger than manageable increases some have asked for, we have been able to, in more instances, successfully introduce alternate payment model or value-based arrangement. So that does bring an element of, yes, risk to the provider for maybe the increase that they're looking for, or maybe additional payments for achieving quality metrics and value scores. And we've seen a lot more adoption in that space than we had in our experience prior to pandemic.
I have a feeling some of our younger listeners are Googling, what is a fax machine?
I was going to say, well, the health industry keeps the fax industry alive. State government will help continue to delay the retirement of COBOL programmers for IT systems. That's another one to Google books.
They're actually retired already, Dave. We're bringing them out of retirement.
Yes. Well, here at HCA, some never retired. There was a question I was just going to ask. Well, I wanted to check in on our board members who are virtual to make sure that we haven't missed anyone's questions that you want to raise in this area. So just opening up real quick to see if we've missed any board member questions that aren't. Check on that.
Michaela's channeling everyone.
Yes, Michaela's.
No questions?
Go ahead, John.
No question.
Oh, no question. Well, I think
That's our panel.
that was our panel. So just wanted to thank Ty and Denise for sharing the insights. This is obviously a very important topic. One of the things here we've been doing at HCA is trying to standardize our communications on when these events happen, but also do a little bit more proactive information within kind of our newsletters, just to kind of apprise people of what the situation involves and some of the complexities of it. But I just really appreciate the work of our partners. And again, thank Denise and Ty for coming today and sharing insights with the board and the public about this topic.
I very much appreciate it. Thank you.
Thank you for having me.
Thank you. We appreciate the opportunity.
I'm looking at the schedule, thinking about where we're at. I'm wondering if you want to bring Alyssa up. Based on time, it's about a 25-minute presentation. We've got OFM scheduled at 10:35. Yeah. What do you think?
And we also did want to do a brief break somewhere and all of that.
The
So,
folks
or check
feel
in.
like we need to take a break now, or we want to hear the next presentation, then maybe do a break between that and OFM.
Why don't we just have Alyssa come up?
Got it. Stacy's on, right? Okay.
Thank you, Don, as well. All right, we're gonna jump over a presentation. We're gonna go with the Plan Year 25 Open Enrollment Summary. Alyssa Richards, our Benefits Account Section Manager, and Stacy Gofftiza. Is that correct? Okay. Customer Service Manager and PERB are going to be presenting the agency's efforts during and the results of the PEB Program Year 2025 Open Enrollment. 2024 Open Enrollment for 2025 Plan Year. There we go. Alyssa's materials are behind tab number 4. Alyssa, welcome. And Stacy, welcome.
Good morning, Chair McDermott and members of the board. For the record, my name is Alyssa Richards, and I'm the Benefits Account Section Manager. And I'm here today to give you an update on how open enrollment went. Next. So first, I wanted to talk about the different areas that focus on open enrollment and benefits accounts section. We have the customer service unit, which is the first line of contact for our retirees and continuation coverage members. Staff in the customer service area have 3 primary functions. They answer calls via the toll-free line and respond to HCA support inquiries, which is a secure email process. They provide in-person lobby services for walk-in members, and then they review members' retiree and continuation coverage eligibility as they process the form. Next slide. And then we also have the outreach and training team who support agencies and organizations for both the PEB and SEB programs, who in turn act as the first line of customer service for their employees. Outreach and training provides training to the benefit administrator staff of these entities regarding program plan options, covered benefits, eligibility, rules, and enrollment processes. When these agencies or organizations have questions or need additional assistance, they do reach out to outreach and training through a dedicated toll-free line or a secure online correspondence tool, HCA support. The outreach and training unit also supports the in-person benefits fairs across the state of Washington during open enrollment. Benefits fairs, just as a reminder, are in-person scheduled events where employees or retirees can learn more about health plans and benefits. And the dates, times, and locations are advertised in our October newsletters as well as on our website.
And also, one of the things I want to highlight for the board, just for context, is our outreach and training unit supports over 700 different employers between 296 school districts, 9 ESDs, 110 agencies if you don't, state agencies if you don't count sub-agencies, 37 CTCs, 6 four-year institutions, and roughly 250 to 300 local governments that contract with the healthcare authority. There is a lot of variability, and that team is somewhere around, in my mind, 15-ish staff that are doing the support of the various employers. So we work in a very decentralized program where I'm talking about the staff that support employees and retirees that are here at Cherry Street Plaza working for HCA. But there are literally thousands of individuals that we call benefits administrators. That's the phrase we use, but that's the home agency or employer's payroll department or HR officer or benefits officer. It has a variety of different names at the employer setting, but they are really on the front lines. Part of the reason the system was set up that way, at least my understanding from the grand design, if you will, is those individuals are closest to the employment relationship. They know what the employee pattern is. That's why they are in the best position to make the eligibility determination based on the guidance and framework that is established by the state. And so just wanted to highlight a little bit about the system, and that will get into some of the volume of work and sometimes the wait times and the amount of processing that needs to happen to support, again, over 700 different
shocked you can remember all those numbers, so that's pretty impressive. All right, so the customer service and outreach and training units work with other HCA divisions on open enrollment activities throughout the year. Some examples are preparing the enrollment systems, which would be Benefits 24/7 and our Pay-1 system. They update the plans available by county, premium amounts, messaging, etc. The outreach and training unit secures vendors, locations, and schedules for the in-person benefits fairs. And we offer pre-open enrollment training for benefit administrators in October to prepare them for open enrollment. And then we also continued work on the virtual benefits fairs. Virtual benefits fairs is an online website created with the same goal in mind as the in-person fairs, but members can learn about their benefits from their home. It's available anytime, day or night, and it can be accessed via computer, tablet, or smartphone. And then some carriers provide direct interactive webinars, pre-recorded webinars, and then teleconferences to share plan-specific information. Next. So now some highlights. Open enrollment dates changed this year for PEB. It was scheduled for October 28th through November 25th. We did extend the date for members to submit paper forms until 11:59 p.m. on Wednesday, November 27th. And this was due to the significant power outages throughout the state based on the storms that happened the week prior, the week of November 18th. So we did send a message out to benefit administrators. We posted to our HCA website. And for those who were enrolled in email communication, we did send out email communication to members. Navia, which is our FSA DCAP vendor, they were able to keep their online enrollment system up through 11:59 p.m. on that Wednesday, and they also accepted paper forms.
Also, one of the things that I think is, again, context is, I guess, my word of the day, to share is some people may wonder, how were we able to have part of our benefits portfolio continue to have electronic enrollment, but not other parts? And so one of it really has to do with I referenced COBOL programmers earlier, some of the agingness of some of our IT systems, and the fact that our online portal, Benefits 24/7, has data migrations with our accounting and eligibility platform, and some of the limitations that exist within a system that was created almost 50 years ago really limit the number of days that there are available for data migrations. And we were really at a point where we needed to begin data migrations on Monday the 25th, the night of the 25th, while still being able to capture changes that were happening and be key because of forms, but we really couldn't extend the electronic version of Benefits 24/7, whereas Navia has separate enrollment platform. And so they were able to do that, and their data integrations with the healthcare authority don't come until earlier in December. This actually is one of the reasons, one of the contributing reasons to the shift in dates of open enrollment. Melissa highlighted a change that was a couple of years coming, but for decades, the PEB program worked on an open enrollment for the calendar month of November. Because of the complexity of data migration, because of the interactions that need to happen with CMS on the retiree side, trying to create even a few more days room may improve the odds that individuals get physical cards as early in January as possible. It just creates a little bit more space there. And so the other challenge that I like to highlight is whenever open enrollment ended on the 30th, and the 30th was over the weekend, as it would have been this past year, there's multiple days where individuals don't have anyone they can turn to for support in those final days of open enrollment. And that, in our data, historically bears out in additional volumes of appeals. And appeals take a long time and have a lot of retroactivity issues then, and that no one likes to be in appeal land. So all of this is just to reinforce that we are permanently shifting open enrollment to this last Monday of October through the Thursday before Thanksgiving model, and we'll publish those dates every year. It's still a very robust multi-week period, but it is a permanent shift that began this year and will be continuing.
Just to clarify, I think you meant the Monday before the Thanksgiving holiday, not the Thursday.
Oh, I'm sorry. I even heard myself say Monday, so thank you for clarifying that. Yep, a Monday to a Monday.
So from the first day of open enrollment, October 28th, through the scheduled last day of open enrollment, November 25th, there were 62,000 PEB members that were able to log in into Benefits 24/7 system. Clinton will be going over some additional information on Benefits 24/7 during his presentation.
Can I ask, like, what percentage of PEB members is that number?
I guess now that I'm hearing the word member, this probably should be the word subscriber on the slide. Remember, so subscriber is the account holder, or more synonymous with what most people think of as the employee or the retiree who has the account. Member incorporates all of the dependents.
Like 250.
So 62, if we say 62,000 subscribers, there are roughly for state, for the employee side of the equation, there's about 128,000 state or higher education employees at any given point. And the retiree population subscriber count is roughly 65,000. So if you add those together, we're talking about 195,000, but you have to subtract around 30,000 to 35,000 because the University of Washington employees don't use Benefits 24/7. And then you also actually have to subtract out Washington State University employees who use a workday system, and then there's a different process for getting theirs in. So we're probably talking somewhere around 145, 150,000. So
42%.
40% was what I was going to say, 42%.
And I guess like the follow-up question to that is that a goal number? Because I know not every, like, people are still going to use paper forms and all of that, but just hearing, I'm channeling Elliot now around like just kind of some of the challenges with using SAW and getting onto Benefits 24/7. Like, is that the right number, or is there a goal to try to increase the percentage of people who are accessing it?
So the part that I think we'll have to come back and do is a ratio of people who are engaging in a given open enrollment and if they're engaging in paper or online, because we don't expect that everybody is going to make a change every year. This year is a little unusual in that we had the shift to standalone vision hardware coverage prompted that most individuals may want to engage. However, we also communicate, if you don't engage, this is the plan that you'll be put into. And so if somebody's happy with that, they don't want to deal with the system and they don't want to engage, there's no reason for them to engage. So I think it's a good point that we can bring back what the ratio is. I don't think we have a specific target at this point, but I don't think we've analyzed it as electronic versus paper. So we can certainly follow up with that.
So there was also no downtime in Benefits 24/7 during open enrollment. On October 28th and 29th, though, we did get reports of intermittent SAW login issues, which were reported to WATEC, which WATEC is the agency that supports that SAW portal. And then we also made paper forms available online on our website. So typically we have those available for the benefit administrators, but we made them on the public HCA website for employees to access easily. And then the outreach and training team also received 2,108 HCA support requests from benefit administrators during this open enrollment period. So we continue to use member feedback for our benefits fairs planning this year. We hosted 15 fairs across the state. Locations for the fairs were selected based on member enrollment data. We also supported 4 fairs that were hosted by the University of Washington. We increased the staffing at these fairs to help support the needs of our members. We started planning earlier for more of our program staff to attend to address member questions. This year, we continue to offer the virtual benefits fairs, and we saw a significant increase in the number of visitors for the virtual benefits fairs. This year, there were 93,675 visits. Compared to last year, there were 12,997. And a big contributing factor to that is the vision changes for this year. So now I will pass it over to Stacy, who can talk about open enrollment, how it went for the customer service team.
Thank you. Good morning, Chair McDermott and members of the board. For the record, my name is Stacy Proctisa. I'm the Customer Service Operations Manager. On this slide, I wanted to provide a visual of our phone trends for 2023 and 2024. The top graph represents the number of calls we answered each month in 2023. The number at the top of each month in that graph represents the total number of calls for that month. The number along the black line represents the average wait time to speak to a customer service representative for each month. So for example, in the first column for the month of January in 2023, there were 3,284 calls with an average wait time for callers of 48 minutes. There are some differences between the 2 years. In January and February of 2023, the higher wait times can be attributed to a lower number of fully trained staff available to take calls, along with dedicating more staff time to processing the increase in open enrollment forms received during the 2022 open enrollment. You can see in 2024, we were able to make improvements to the wait times at the same time answering more calls. I will call out in October and November of 2024, the wait times were higher than in 2023. But again, that can be attributed to open enrollment starting in October, along with an increase in the number of calls. Overall, we were able to make improvements in 2024. We answered more calls compared to 2023, with a decrease in the yearly average wait time, going from 14.4 minutes to 10.9. And I'll discuss more open enrollment details related to the phones on a later slide. Next slide, please. Our business cycle pattern is similar year to year. Knowing the ups and downs throughout the year helps us plan work and activities to meet those changing workload demands. In 2023, we received 31,633 documents. In 2024, we received 26,237 documents. There was a decrease in the documents in 2024, but a very similar pattern month to month. The decrease is due to the launch of the Benefits 24/7 system in January of 2024, which allows members to submit requests online instead of submitting them by paper. As you can see the slide on the slide, November continues to be our highest number of documents received, and that is of course due to open enrollment. Next slide, please.
Stacey, real
This
quick,
slide represents.
before we move on from documents, there's a nuance that I want to just make sure people are aware of, which is even though a member may do an election through Benefits 24/7 online and not issue a paper document, that does not mean that all the steps after that are automated. There are still manual steps that are done. It does expedite and save time on a lot of manual keying processes, but some people may assume that an online election has an expedited path through our process, and it does from the standpoint of that data not having to be input or the account having to be looked up manually in a total manual setting, but there are manual steps, and the journey of that election still has several manual steps along the way. And so just wanted to kind of raise a little bit of awareness of that. And Michaela has a question.
All right. Just like as I'm looking through the data, I'm trying to understand, like I see on the phone call number that the number of calls went up in 2024 comparatively to 2023, and that's like throughout the year, every month. But then the number of documents received throughout the year went down in 2024, and then the number of like just looking at calls and like 9,553 comparatively to like 5,000, 6,000. Do you know from like what's causing the increase in calls, even though the document like product is going down?
Oh, go ahead, Stacey.
I would still say, you know, the biggest thing related to like where the documents, or I'm sorry, where we were able to answer more calls is that we had more staff available to answer calls, and so we were able to get to more calls because of the number of staff we had. And then regarding the documents, what I don't have on this slide is a number of Benefits 24/7 requests that we had throughout the year. And so while it looks like we got more documents in 2023, compared to 2024. We did, but that's not to say that we didn't get as many, if not more, requests, that kind of matched the number of documents in 2023 compared to 2024. Hopefully I said that correctly. Or does that make sense?
Yeah, thank you.
And so documents on slide 8 is about paper documents. And I think going forward after this year, we'll also do a similar trend piece on the online electronic enrollments and kind of thread that together. Before I turn it back to Alyssa, who's going to add something else, I think I do want to highlight that slide 7, that the slide Stacy's presenting is just the retiree population. Our customer service center that provides direct customer support is designed for and servicing retiree accounts. So none of this data is inherently about the employee population. We'll go to Alyssa, and then I know Kirk had your hand up for a question.
The one thing that I would add though is the customer service team was answering login help calls for all populations for benefits 24/7. So that is a contributing factor to the increase in calls as well.
Kurt?
Thank you. Can you hear me okay?
Yes.
Okay, great. So, I just had a question about the phone calls, recognizing that there was obviously much more calls in 2024, although the average wait time decreased over the year. In October, November, December, they were up significantly. So I guess my question is that an acceptable wait time in the staff's opinion, or is that something we're looking to change? And if so, what are we doing? It seemed, 41 minutes to wait on hold to me seems like a long time. But maybe, maybe it's not. I don't know, but just curious.
No, we are definitely looking for ways to make improvements. Yeah, that is a long wait time. We recognize that. And we are looking for ways to try to improve that. It's just with the volume of calls during that open enrollment time, that continues to be our challenge. So looking for ways we can provide more self-service options for members so that they don't have to wait on the line, is one of the ways we can help drive that number down.
Okay.
Kurt, one of the other challenges that exist, and none of this is to assign blame to anyone, and I've tried to describe the circumstances in which all of us are working, the data could support having many more staff for a few months of the year, and that same data makes it challenging to say that staffing level is necessary throughout the year. And that is a perennial tension in the staffing model, and when there are budgetary requests related to additional staff, is trying to find a time, make sure that the staffing model isn't significantly overstaffed at the times of year where that staff isn't supported. And so I would venture to guess that it would be hard to find anyone who thinks that a 40-minute wait time, and that's an average wait time, which means there are periods where that is higher. There are periods where that is absolutely higher. It has definitely, in the past couple of months, has crested at different points on the highest point of a day into the 90 minutes, or even reaching almost 100 minutes at different points. And I don't think that is what anyone would define as an acceptable wait time. We have at this agency in the past couple of years, one of the metrics that we've measured against is average speed to answer at a given point is ideally no more than 10 minutes, and ideally, more ideally, under 4 or 5 minutes as a wait time. So some of the things that we've done over the years to get the numbers where they are, which still has a long way to go. As Stacey highlighted, some self-service options. We've tried to triage how our phone tree works with the, I forget what IVR stands for, interactive voice recognition process. There, I just made up the R, where it gives a couple of options that some people want a form mailed to them, and so they can press a button and it gets the form with us. Or we change the order that things are presented because some people want to go to accounting, and rather than waiting on hold and then getting transferred to accounting, they hear that option an earlier option is accounting. I don't want to say a number because I'm going to say whatever number is wrong and then that'll end up being used. To get them to the right place for some of their questions, or they want a packet mailed to them. And so we have some things that we modernize in that way. We also have the ability to change what we call the rolling message. So if there is a hot topic that's happening, we can try to get that on the rolling message. And sometimes that answers the primary question people are calling for. We've also, we look at our hiring patterns. And at one point, we recognized that we were in a perpetual hiring pattern. And so, we hired an extra staff or two so that when there is an inevitable departure of a staff member, that we're more closely approximating what our full capacity is supposed to be. That's, in budget speak, that's scooping up variance and strategically investing in it immediately. And so we've done some of those pieces. There was an investment by the legislature, I believe it was about 4 years ago. We used to have 2 teams within our call center, customer service center, and then we moved to 3 teams. And that allowed us, I think, to go from about 22 staff to 27 staff. And so we did do an expansion of that as well. So the short answer, Kurt, is no, we don't think 41 minutes as an average is acceptable. There are pieces that are running along, and there is the complexity of having there's always a budgetary tension on balancing the non-high points of the period with the high points of the period. And it's something that state agencies who have customer service metrics and cyclical aspects to their work struggle with regularly.
Yeah, I appreciate that, Dave. Thank you. And I guess just a couple of follow-up comments and a question. Assuming that you were fully staffed, that there weren't vacancies, right? And I don't know how many positions you have doing this, but I don't know if the agency's ever considered seasonal work, right? Or temporary work during a workload peak like this, which to me would be, an idea. But, also, I don't know if you track it, but, we also run a call center and have a large volume of calls, not nearly as this much, and we noticed that when the wait time is that high, the number of drop calls goes up exponentially. And so I don't know if you track that, but I imagine there's a lot of people that just give up, and then those folks aren't being helped. And maybe that's an obvious thing, but I didn't see a graph on that. But thank you for the information.
We do track drop calls, and we have looked at seasonal work in the past. One of the things that we did to allow us to at least think about that, because this work is specifically geared towards the bulk of it towards retirees, is some of the most complex parts of eligibility involve the retiree Medicare and non-Medicare setting. And so being able to triage what is the level of training necessary to get to a certain point to assist with some types of questions versus other types of questions on that complexity is something that we've evaluated. We did modernize our training environment and to kind of segment different parts of that complexity training to get people on the phones earlier for certain types of questions. The other piece that we do that it's not seasonal worker, but it is something that can happen from time to time, is this agency runs another large program that people are aware of called Medicaid. And there are hundreds of individuals who are part of the customer service team for Medicaid. So there are times where we are able to leverage staff that volunteer from the Medicaid program for brief stints to help with some of those more easily trained components of our eligibility framework, or how to log in, or where to get a form, and or how to adjust and check on the status of something within their account. And we do leverage that at different points whenever possible with that Medicaid staff spillover. So that is something that we've done that kind of starts to sound a little bit about the seasonal worker. Whenever we see these cyclical pieces, we are able sometimes to leverage that. Stacy, back to you.
Thank you. So on this slide, we represent the number of in-person lobby visits, both in 2023 and 2024. You can see a similar pattern, again, which occurs from year to year. We saw an increase in October of 2024 compared to 2023, and that was due to the open enrollment starting in October. So knowing those significant increases in the lobby visits during open enrollment each year, we do increase staff dedicated to assisting guests in the lobby because we do recognize that this is a very important service that we offer members. Next slide, please. All right, so on this slide, I included a matrix of the from 2022 to 2024, specific to customer service data at open enrollment. The column on the left includes the interactive voice response, which is a self-service option. Members can check their enrollment status, request OE packets and retiree guides, as well as check to see if their forms have been received. The next item is calls to speak to a customer service representative. We had a significant increase in calls answered by a representative in 2024. The matrix also lists the wait time average, which is the time it takes to reach a representative. There was a slight increase in our average wait time in 2024 compared to 2023. Going from 36.7 to 39.4 minutes in 2024. And I will note those, I think Dave already mentioned it, but those averages, that is an average, and that there were times throughout open enrollment where the wait times were higher. Next is the callback feature utilization, which allows callers to the option to hold their place in line and receive a call back when they are next to speak to a customer service representative. Next is the number of lobby visits, open enrollment forms received, benefits 24/7 requests, and the number of HCA support tickets received. One of the toughest challenges we face is processing open enrollment changes timely when we have a high call volume. Every year we have a significant increase in forms during open enrollment than at other times throughout the year. While you can see a decrease in the paper forms received in 2024, we did receive and process 2,068 benefits 24/7 requests that were submitted online by members during open enrollment. I will also mention that includes the vision elections for non-Medicare members included in that number. We were able to dedicate more time to processing documents and requests from the start of open enrollment, which allowed changes to be processed more timely. Because we were able to start processing those changes sooner, confirmation letters were sent daily to subscribers as we processed those changes. I also included the number of fully trained staff available at open enrollment for full customer service duties. We had 22 fully trained staff during open enrollment, which made a significant difference than in years past. That aided in a successful open enrollment. Customer service was able to answer more calls, assist members in the lobby, and process forms more timely, which resulted in the majority of our members being notified of their changes prior to the start of the 2025 plan year. And I will send it back to Alyssa.
Thank you, Stacy. So now I'll go over some of the data from the changes made by members during open enrollment. So on this slide, you can see the list of medical plans for PEB employees and non-Medicare retirees, the total number of enrollments in each plan in 2024, which is a snapshot in October 2024, just before open enrollment began. In the 2025 column, you can see the total number of members enrolled for 2025. In the fourth column, you see the change from enrollment in 2024 to 2025. I've highlighted in red the enrollment changes in each plan that had a decrease in the overall enrollment from one year to the next. You can see some plans had significant changes, such as the UNP Plus PEBB medicine plan had a decrease of 3,401. And we can attribute that to the changes in premiums for 2025, where UMP Classic was actually a lower monthly premium for a single subscriber. Next slide, please. You can see changes for our Medicare population on this slide, and we saw a big increase in enrollment in the United Healthcare PEB Complete Plan, 2024 to 2025. As I mentioned on the previous slide, you can see the decreases for each plan in red. And just as a reminder, Plan F has been closed to new enrollments since 2020, so we typically will see a decrease there just over time. And Laura Ryan is going to be giving a Medicare presentation, and so she'll have some additional details as well. Next slide. On this slide, you can see what plan members started in and which plan they switched to. So I wanted to highlight just a few examples. You can see Kaiser Washington Medicare plan had 1,174 members switch to United Healthcare PEB Complete. In the light blue bar, you can see 1,274 members switched from UMP Plus to Uniform Medical Plan Classic. And then the bottom thick orange bar shows 980 Uniform Medical Plan Classic members switched to the United Healthcare PEB Complete. Vision. So on this slide, you can see the vision enrollments for 2025. You can see the significant difference in enrollment for the MetLife Vision Plan, and we attribute that to MetLife being the default vision plan for folks who did not make a selection during open enrollment. As a reminder, we publish the open enrollment switching reports on our website each week during open enrollment that anyone can access. Once open enrollment is complete, there's the final switching report that gets posted to our website. And at the bottom of this slide, I've also included the link to our website where enrollment reports are available to anyone who may be interested. Okay. That is the end. Are there any other tips?
Any questions for Lieutenant Stacy? All right, thanks, folks. We're going to go ahead and take a 10-minute break, and then Emma's going to tell us a little bit about the budget. Let's go ahead and get back together at 10:50. Thank you. All right, we are back. Board meeting is ongoing here. Let's go ahead. Our next update is going to be from the Office of Financial Management. What is OFM? State budget update. Robin Williams, the interim budget director from OFM, is going to provide us with our current state budget circumstances. That's a word. Robin's material behind tab number 3. Welcome, Robin.
Thank you. How do I do this? Okay, thank you.
Yeah.
It's nice to be here. Very much appreciate my benefits, so thank you very much for your work. I am, as Lou mentioned, I'm the interim budget director at the Office of Financial Management as of Monday. And before that, I was the deputy budget manager. So, and have worked in healthcare budget basically for my whole career. So, I'm happy to be here, and we can go to the slide. The purpose of my time here is to talk about the budget in context. We'll look at revenue forecasts and talk about updates. We will talk about requirements for the governor's budget and the legislative enacted budgets. And then I'll briefly touch on Governor Inslee's proposed budget at a very high level and compare it at a very high level to some priorities that Governor Ferguson has outlined. And then I will end showing you where in the timeline of events we are. So in Washington, the entity that sets our revenue forecast is called the Economic and Revenue Forecast Council. They are it's an entity it's an agency in statute. It's a board. They have 4 quarterly forecasts that they put out, and you can see on there it says near general fund revenues. And when I say near general fund, I mean there's 3 or 4 accounts that are the most flexible state funds that so we kind of lump them together. They're subject to what's called the outlook, meaning they have to balance over a longer period of time. And so together with the reserves from prior biennia, so meaning revenue that was available for the legislature to spend in their budget, but they didn't. So it was left on the in their bank account, basically. So that's the reserves plus what the forecast is. That tells you what the available resource is for whatever budget is being considered. As you can, so for the governor's budget, he or she is required to use the November forecast. And in November, you can see here that revenue was down a little from the enacted budget, which is February. So those numbers are large. 615 million is not a small number, but the percentage you can see is very small. So I would say that's mostly flat, but trending downward. And the revenue forecast uses almost always uses unemployment, employment growth, oil prices, consumer price index, the sort of normal things you hear about in economic news. And then right now they're using international conflicts as a part of the consideration. And the new thing this in November was that they included potential impact of any tariffs, any potential tariffs that might be coming down the pike. Okay, so New York General Fund, this is to illustrate where that comes from. The largest funder of the general fund is the retail tax, sales and use tax that we all pay when we go shopping or buy something where there's tax on it. Business and occupation tax, that's taxes that businesses pay for their operation. And then property tax, we all, or people who own property, all pay property tax. And then there's the other, and that includes, I need to look at the thing here. Liquor sales, tobacco, insurance premiums, which the fun fact there is our insurance tax is the oldest tax in the state. And so capital gains is also included in that other tax bucket. And then the last smallest funder of the general fund is real estate excise tax, sometimes referred to as REIT. And that is basically sales tax for when you're buying real estate. So that, with the prior slide was like what goes into the general fund, and then this slide is to show how the general fund is used and what part of the general fund is basically protected by law that we have to fund these things. And then, so that's the, I would say maybe pink, maybe raspberry part of the pie chart, maybe red. Your mileage may vary on that one. And that's things like debt service and pension contributions. Those are required in the Constitution. There are some entitlement programs. TANF, there's temporary, it's either aid or assistance to needy families. That's kind of what we would, the modern day iteration of welfare. It's cash assistance. Financial aid is an entitlement. Medicaid, which this agency also does, is an entitlement if you meet the qualifications for, if you're a child who's in foster care, you're entitled to get your Medicaid, your health care paid through Medicaid. That's an example. K-12 is the biggest entitlement in state, and it's the kind of paramount duty. If you're 14, you're entitled to a public education, et cetera. So correctional institutions, not quite an entitlement, but if you are sentenced to time in a correctional institution, the state has to fund that care for you. And working families tax credit, that's a pretty new entitlement, and it's for low income people, basically. And then the state has to fund the courts. And then by law, we have to transfer, I believe it's 1% of it's 1% of the near general fund revenue, I believe. Each budget has to put that into the budget stabilization account, which you will sometimes hear referred to as the rainy day fund. So transfers into it are required, and it can be, the governors or the legislature can propose spending out of it, but it is difficult to transfer that money back into the general fund. It requires like a 2/3 vote. And then examples of not required spending include our higher education system. Some things that you think, like higher ed, that you think are like a given that the government might be working on, include public health, natural resources. We have beautiful state parks. That's not required, but it is very nice to have. And then state basic operating costs. That would be, paying for the agency that I work for is a basic operating cost. So paying for the attorney general, or the department that does maintains buildings, things like that. And then reserves. And as I mentioned at the beginning, reserves are like available revenue that has not been spent. I will say that's not required, but rating agencies, for when the state issues bonds, we want a high rating because it makes us a better investment. They really value both the budget stabilization account and reserves. So we want to kind of protect those.
Robin, before we leave this slide, could you talk a little bit about collective bargaining and where that falls on the two sides of the scales at times? Because this group and benefits are intimately related to the CBAs.
So the way I would describe collective bargaining is a signed agreement that has been funded in the past by the legislature probably falls out on both sides. There are collective bargaining agreements that work on there are bargained units in natural resources. So that's not required, but this is my big asterisk. Once the legislature has funded a collective bargaining agreement, it has to adhere to it. A proposed collective bargaining agreement is kind of not on this. It's up to the legislature whether to fund it, essentially.
Thanks, Robin. Just wanted to put a point on that one, though.
Sure. This is sort of just a background on how the budget is built. And if you ever look at it in detail, you might see some of these terms. Carry forward level is, so there's like the base of like whatever, we don't zero-base budget in Washington. So all proposed budgets are built on top of prior enacted budgets. So carry forward level is an exercise where we fund things to have longer term impacts that might not have been contemplated in the enacted budget. So for instance, if something started with only 6 months left in a year, like halfway through the year, carry forward level would put the other 6 months, so there's a full year's worth of funding. If something was funded and it was supposed to be a one-time thing with a report or something, an emergency, so they just needed one time worth of things, carry forward level will be the exercise that removes that from the budget. Maintenance level is the updated cost of current services. So, how many, and that includes changes in caseload. So how many more K through third grade kids are going to be in the schools? That would be part of maintenance level, or the utilization changes for Medicaid those two things basically are the big two drivers on costs for maintenance level. But if there's caseloads and other things kind of throughout the budget. Or like if the cost of stamps goes up and an agency sends out a lot of mail, that like the 15-cent change or whatnot might be something that's included at maintenance level. And I mentioned changes in caseloads. There, like the Economic and Revenue Forecast Council, there is a caseload forecast council, and they are the entity that forecasts the caseload utilization of state entitlement programs. So public schools is the big one, long-term care, medical assistance, Medicaid, foster care, adoption support, all the things that you can kind of see listed there, the prison population. And now working families tax credit is also forecasted by them. And they do 3 forecasts a year compared to the 4 that the Economic Revenue Forecast Council does. Okay, so this slide is to illustrate how our state budget splits out by like kind of type of government program. I believe this is based off of the 23-25 operating appropriation. So it's not the budget that the Governor Inslee proposed. It's the one we're kind of operating under right now. K-12 is the big driver in state funds. As I mentioned, it's our paramount duty, and that's 43% of the budget. And then the next big chunk is human services, which includes Medicaid. It includes all of Department of Social and Health Services, which is long-term care and services for people with behavioral health issues and developmental disabilities, people at the state hospitals with behavioral health issues. It includes TANF, it includes public health, and all sorts of things are in the human services bucket. And then the next one, the green wedge, is higher education. It's 8%. Why these the title anyway. The general government is 3%. So again, that's like my agency, the Attorney General's office, just kind of the nuts and bolts of government. And then natural resources is 1%, and other is that gray box. It's 7%, and it is things like debt service and pension contributions. There's 2 agencies that we consider transportation agencies that actually have operating. They're included in the operating budget, and those are State Patrol and the Department of Licensing. So they're in that other bucket, and then any special appropriations are in that gray bucket. And now this is to show what the operating budget framework was for Governor Inslee's proposed budget. The top part is about revenue. So there was a beginning balance, that's basically unspent revenue. And then there's the forecasted revenue. And you can see, it's about 73 for this current biennium, 73 billion. And then around the same for the next biennium, and then a little bit more in the out years, 27, 29. I don't know that I mentioned this specifically, but usually we're talking about a 4-year budget. The biennium that we're in, and the next one. But because the biennium that we're in the last year of it, so it's more of a 5-year situation. And then you can see the appropriations there. The interesting thing about the new Governor Inslee proposed, those numbers are very small compared to prior years proposed. That's what we call like new policy ideas, new things. That's like 40% of what we would have seen in the past. So having the line before and which has kind of all of the broccoli, if you will, of the budget, like just paying for the stuff that we already do. Basically, this is to show that the fundamental disconnect here is in the current cost of what we're doing, not in proposed new ideas in Governor Inslee's budget. You can then see the Governor Inslee proposed about $2 billion in reductions over the 5 years, and then all of that lands to being out of balance, as we would say, or being in the red, if there's no other interventions. Governor Inslee also proposed revenue, and that is how his budget balanced is the new revenue. This slide is mostly to show you, this is relevant to your interests, I guess is how I would say it. These are the collective bargaining agreements that were funded in Governor Inslee's budget and that the legislature is considering. I know that the PEB and SEB lines look weird, and I think, Dave, can you speak to that?
Yes, Tanya will go over this a little bit more in her presentation later, but the reduction that you see here is actually a one-time fund transfer from some of the external reserve account for the long-term disability benefit, and specifically the employer paid benefit side of the long-term disability benefit. Tanya, again, we'll talk about this, but some reserves have built up because of favorable claims experience in recent years. And so these are some transfers that are envisioned to go directly back into the general fund. Again, they are employer paid only dollars. There's no employee premiums that contributed to those reserves. So more later, but that's the totality of what those reductions that are on the sheet represent.
Thank you. Okay, and so this slide, I think we're close to the end here, but is really to show you, there's a high level summary there. Governor Inslee proposed $2 billion of reductions. There's new appropriations that are much smaller than in prior budgets, and $13 billion in new revenue. And he instituted a hiring freeze, contract freeze, purchases, and travel, and that was in October, November, December 5th, just like I said. And thank you. And and then to kind of contrast that, Governor Ferguson has outlined his priorities of a $4 billion goal target of reductions, which is approximately 6% for most agencies, 3% for the four-year higher ed institutions, and then there's a few entities that are exempted. For instance, our public safety agencies, like the State Patrol and Department of Corrections, and the Criminal Justice Training Board or Commission. And then also our K-12 entities are exempted from this, and the community colleges. So, but for most, the vast majority, it's a 6% target of general fund and other fund. There's some strategies outlined in his priorities, including management consolidation, reduction in travel and equipment, and to suspend legislative reports. And then there's an exercise going on right now where agencies are reevaluating, are looking at those things, and then also reevaluating their programs to see if they are part of their core mission, or if they still make sense to do. The priorities that Governor Ferguson has outlined for new appropriations include grants for local law enforcement, money to get through the backlog at the toxicology lab. He wants to address housing, ferries, make free school lunches universal, and then increase the eligibility for childcare, so for supported childcare for employees at small businesses. And he has indicated that he's only interested in new revenue as a last resort. So a little different. So there's some activity around that going on right now at the agencies to kind of identify potential reductions. And lastly, the timeline. I wanted to remind you of the timeline. The Governor Inslee's budget was based off of the November caseload and revenue forecasts. He put out his proposal on December 17th. The legislature has convened. We're in like week 3 or 4, feels like a million. And the caseload forecast will be in Valentine's Day, I think, in February. And the revenue forecast that the legislature will use is going to be about in mid-March, I believe. Legislative session is scheduled to end on April 27th, and any bills that are sent to the governor at the end of session, including the budget bill, he has 20 days to sign. So, or veto it. So that should be May 20th, assuming April 27th is the end of session. That's what I've got for you.
So for the board, one of the reasons we wanted to have Robin come and share about the extent of the budget challenges that the state is facing and the governor's office and the legislature is you're very aware that throughout the year, there is advocacy to this board. And much of that advocacy, or a significant piece of that advocacy, is requests to evaluate and add additional benefit offerings to the table. At any given year, it's a variety of different topics. And really, that's going to be a very challenging proposition for the programs. The types of things that state government will, state government tomorrow or, after the next biennial budget will look smaller. I think it's safe to say state government will be smaller in the near future than it is today. And when there are lots of different choices being weighed, enhancing benefits in our employee-sponsored insurance programs is probably fairly low on the list of priorities. And so, just an awareness that if there are going to be any benefits, they'll be probably driven through the state budget. You're all, I think, aware from the last operating budget that there was a specific carve out, for example, on anti-obesity medications, GLP-1s, that expressly says that that is going to be a squarely legislative funding question, an operating budget question. And I think it's safe to say that several other large benefit ideas that are regularly discussed are, if they were to occur, it will be in the context of the legislative budget, specifically authorizing additional expenditures. That's kind of a long way of just giving context to that. There's much less offense, if you will. It's more defense in this kind of budgetary environment, and just to kind of help temper expectations around some of the typical conversations we have about ways to refine the benefit package. So we'll talk a little bit more about the benefit cycle later in the board meeting, but I see some questions. I don't know if they're for me, for Robin, for Lou, but we'll start with Tom.
Thank you. And by the way, Dave, if you think that these are probably, I don't want to hijack the meeting, but these are very specific to education. If you could go to slide 6 for just a moment. So I want to just ask, I'll tell you what, I'll phrase the questions, and then if you'd like, I could probably carry this conversation on with Robin through email, but I'll just put the questions out that I have. One, under examples of required spending, K-12 basic education, is that following the state definition of basic education, which does not include art, physical education, and counseling services and librarians?
I think that is so let me say, I'm not sure within the pie chart situation whether the funding for those types of programs were lumped in with the other K-12 expenses that are, through apportionment. So I don't know where it's falling in the pie chart. But if I'm typically referring to basic education, I would be talking about, like the state definition. I know that specifically on the other side, in the other column, the not required column, the K-12 other programs, that's things like grants and some bonuses and things. It's not classroom things.
And we can take, like you said, Rob, is that we will take a lot of questions under advisement probably. We'll do the best we can today, but we'll definitely do some more follow-up about that exact piece.
Okay, and then I do have one other that I'll just toss out. Under the K-12 other programs, I note that the OFM has requested a bill, House Bill 1475, and that is, I believe, to, I don't know if it's to end or suspend national board certification, but it has a direct bearing on national board certification. I'm wondering what the details of that are. Is it to suspend it? Is it to end it? When would it go into effect, and under what circumstances?
I believe it's to pause it. That's how it's funded in the budget, as a pause. So the assumption is that those are bonuses for those for teachers who attain national board certification.
Yeah, correct. It's a $5,000 stipend, and if you were in a Title I school, it's a $10,000 stipend. Most of the people who go through that program have to put out expenses out of their own pocket in order to do that, and usually it's the length is 5 years. So you have people right now who are just newly certified. You have people who are renewing, and you have people who are in the middle of the process. How is that all going to be implemented? Those would be my questions. And again, if you would like, I can just rephrase those via email, and we can have that conversation later.
Yeah, and I think also that sort of information should be included in fiscal note at some point. So that will probably help answer your questions as well. But yeah, happy to talk to you over email.
Okay, thank you.
Kurt.
Yeah, thank you, Robin, for the presentation. And my question is specific to the dollars that are allocated by the legislature for state employee health care. Understanding what you said, Dave, that, there obviously may not be money or likely no money for any new programs or benefit expansion, et cetera. But as far as maintaining the current funding, and maybe you mentioned this and I missed it. If that's the case, I'm sorry. But, do we know where the legislature is going? I mean, I know that's a broad statement and you can't predict what they're going to do, but I guess what is OFM recommending? Similar, same funding, the agency, right? HCA. I mean, where is that at, I guess, and what can we expect when we get the numbers in subsequent meetings? Here's what the ledge is funding.
Sure. So let me know if I'm not getting to your question, but the Governor Inslee's proposed budget maintained the split for employer, employee, 85-15, right? So that is maintained in the proposed budget from Governor Inslee, and Governor Ferguson has put out information and recognizing the importance of employees. So I have assumed, I think his intention is that that the collective bargaining agreements and whatnot be included in the legislative budget. So I would assume that would include the 85-15 split. Does that address your question, Kurt?
No, but thank you. I mean, yeah, the 85-15, right, is what we bargained, and we know that the contracts were, funded in the governor's budget. I believe in Ferguson, that's his intent as well. And talking to most of our legislators' friends, that's their intent. But again, you never know. But it's and maybe Dave can help me out here. It's the funding that the ledge then, provides to pay for health insurance for state employees.
Kurt,
And
I think
that fluctuates every year,
I think, Kurt, you're asking a little bit more about the funding rate, the specific dollar amount that is essentially spun out to state agencies to then be charged by the Healthcare Authority for eligible employees. Tanya will go over the funding rate implications, and I'll just preview of coming attractions. A phrase that you will continue to hear Tanya and I say regularly is there is no magic number, because there are some various inputs about reserve levels that the legislature and the governor's office can pull to maintain current levels of coverage while it seeming like there's a cut in it would seem like there could be a lower number at some points, but it doesn't have, it doesn't come with an intent or assumption to change things. Some of it's similar to the LTD piece that I previewed. If there are additional reserves, the question of how many reserves to leave in the balance of the main PEB program account is a perennial question that is part of the funding rate. And a lot of times there isn't a substantial focus on the funding rate number until after the March revenue forecast, because that also just drives general trends within the budget everywhere. It's one of the key pillars of the state budget process that just needs to happen around St. Patrick's Day, and then the next steps of the core framework of the budget can be put together. But Tanya will definitely talk through those pieces. In the past, we've been on kind of an autopilot, if you will, of being able to say these funding rates adequately support current changes to the program and nothing else, or includes these other additional enhancements. And Tanya will have a bit more of a complex statement because I think you're right, Kurt, that the number could fluctuate a bit more than we're used to. And Tanya will continue to focus on things like what are the underlying assumptions that build to that number, and are there directions that are inherent in what is being modeled by the legislature? But we haven't seen any of those directions other than status quo at this point. Is that helpful for now?
Yes, that's a number that I'm very interested in, obviously, and its impacts on what we can provide for employees.
I think the important piece to remember is that a lower number doesn't inherently mean a cut in benefits or eligibility or structure of the program, nor does an increase inherently mean an expansion of eligibility or benefits. It is a budgetary number that has a lot of components in it, and so we try to unearth with Tanya what those components mean and any directionality and policy statements inherent to it. But a larger and smaller number in of itself doesn't immediately convey intent or action that is needed in any direction. That's why we say the phrase, there's no magic number, but we will talk about what that number represents as numbers get spun out.
Any other questions for Robin? Robin, thank you so much. Appreciate your time today.
Yeah, thank you. And as I said, I used a lot of my health insurance last year, so thank you very much.
And that's why premiums are going up.
I mean, maybe.
Thank you, Rob. All right, next up, we've got Clint Brooks. Going to come up. He's our PERB solution architect in the Enterprise Technology Services Division. He's going to join us today, give an update regarding our benefits 24/7 application materials behind tab number 5. Clint, welcome.
All right, thank you. Like Lou said, I'm Clinton Brooks. I'm the PERB solution architect. And this past year, I've had the privilege of leading the Benefits 24/7 team through their first year with the system. For my slides, we're going to go over kind of a high-level overview of what Benefits 24/7 is, give you some context on the system, and then we're going to look at the activities we did during our first year with the system, followed by an overview of OE, and then we'll be looking at the pain points that we identified with the system and our steps that we're going to be taking to address those pain points. Next slide, please. So Benefits 24/7 is a centralized access point for members, PAs, and PERB staff to manage their enrollment data. It's a replacement for SEB My Account and provides a digital platform for the PEB population. Previously, they've been entirely paper, and it's really the next step in transitioning PERB from paper to digital processes. Structurally, Benefits 24/7 is one of 2 systems that PERB uses for enrollments, eligibility, and accounting data. It's the front end portion of that equation where folks come in and they manage their enrollments. And then every evening, the data that was changed is packaged up and put into a file that is sent over to the Pay1 system. That's referred to as the sync process. Pay1 system then updates their accounts and sends off files over to the carriers to update the data accordingly. It's also significant to note that Benefits 24/7, the project that produced it started back in the summer of 2020, and we actually deployed the system early last year. And the system is also currently supported by a team of 9, with Pay1 having its own dedicated support team.
2 pieces of context on that slide. One, yes, it is purposeful that you see Benefits 24/7 as a more modern laptop, and that Pay1 is image that some people have to Google, like fax machines. It really is just, it is to underscore that Benefits 24/7 birthday was January of 2024, and we don't actually know the birthday of Pay1, but it is the late 70s. Yes, yeah, as Michaela just said, it is impolite to ask Pay1's age. But we do know things as a good proxy that Gerald Ford was president when Pay1 was created. So just as a historical proxy, or maybe one better yet that people really appreciate is Star Wars. didn't exist. And by that, I mean any Star Wars films, not just the modern trilogies. So just a little bit of context there. And then I do want to underscore, because I know there's sensitivity about this piece in particular, is there will always be some amount of paper in the system. Our journey towards evolving towards an electronic world is never going to be a situation where paper is not an available option. And I just want to reinforce that for everyone who's listening, in case you were concerned that there would ever be a point where there's not paper. Paper will always be an option. And to Michaela's point during Alyssa's presentation, we haven't identified a target for a specific amount of online enrollment, but we are we've been on a journey to not have to 100% rely on paper, but paper will always be an option.
All right, next slide, please. So here you see a visualization of our first year with the system. Back in early January of last year, we were having conversations about whether or not we should go live with Benefits 24/7, and the decision was made that we should, but with the understanding that open enrollment would be the actual launch of the system. Everything leading up to that would be kind of like a soft launch as we worked out any kinks and issues. The initial transition from Set My Account to Benefits 24/7 went smoothly. It wasn't until like the second week after go live that we identified data migration issues in the sync process that were resulting in incorrect data being sent over to Pay One, which it was then updating accounts with. The Benefits 24/7 team, once this was identified, moved quickly to correct these accounts manually, and then implemented measures to prevent this from happening in the future. Among those measures was a process to catch accounts that might be in error, so that staff can review those changes manually. Once we got through go live, the team transitioned over towards stabilization. Stabilization is a common practice with a large system launch of this sort. During this time, the team was addressing defects, data fixes, and maintenance, though the majority of our work was around defects and data fixes. As we were working through stabilization, the decision was made to go forward with the implementation of Medicare Part D and Vision. This was viewed as a specific investment in the retiree portion of the PEB population. Benefits 24/7 was designed with Vision in mind, but it didn't really have support for Medicare Part D. And so the team had to go forward with development and design work to get that support in place. We also then did testing with the carriers to ensure that the data that we would transmit to them could be loaded into their systems correctly. And then we did implementation support activities to ensure that the launch went smoothly. It's important to note, though, that the work around Part D over time began to take more of the team's capacity, preventing us from being able to invest in stabilization to the degree that we had hoped. And so as we got close to open enrollment, we made some pivots to ensure that we could do open enrollment successfully. And these included identifying and resolving a priority set of defects and data fixes that needed to be dealt with, as well as finishing out some functionality that had been deemed not necessary for go live, but was required for OE. Additionally, since this was our first open enrollment with both programs combined, we anticipated a large amount of users in the system. And so we did some performance testing with those user volumes in mind. And we found that portions of the system principally used by benefits administrators had a 50 to 90% failure rate with a response delay of about 30 to 60 seconds. Obviously, that is not acceptable. And so the team pushed forward on addressing that, and we were able to drive that down to a 0% failure rate with a maximum latency of about 2.5 seconds. And we completed all of that work for OE. Next slide. So open enrollment. Open enrollment opened and closed on time in Benefits 24/7. This was a key goal in our planning for OE. We also saw no downtime in Benefits 24/7, despite high levels of activity in the system and a fairly aggressive hotfix delivery cadence by the team. We saw a total of 127 unique subscribers accessing the system across PEB and SEB. 62,000 of those were on the PEB side, with about, that's for the upward. And then for the open enrollment wizard completion rate, we saw a 96.5% completion rate on the PEB side. About 2,000 of those were retirees. And for a little bit more context on what I mean by enrollment wizard completion rate, on the back end in Benefits 24/7, the OE wizard has milestones that track user progress through the wizard. And what we're measuring here is how many users actually made it to that final milestone. Next slide, please. We also had some excitement at the start of OE. We had on the first 2 days of OE a partial outage of SAW. Due to how SAW is set up, we don't have concrete numbers about how many members were impacted. But using the data that we do have access to, we project it was about 5% of users. We also delivered a total of 10 hot fixes during OE, each averaging about 3.5 bugs per hot fix. It's important to note there that none of those bugs that we were addressing involved major breaking or systemic issues. We were largely just seeing types of things you would expect with a system launch or during open enrollment. We also deliberately restructured the team going into OE in order to make it so that we could be responsive and agile in how we addressed these hot fixes. And then finally, for OE, we were able to successfully transmit the data over to Pay1 with no significant issues in the sync process. Data showed up in Pay1 as we had expected, and then Pay1 was able to transmit that data over to the carriers as scheduled.
Before we move on, Elliot, I see your hand raised for a question.
Yeah, very quickly, what is a hotfix?
Good question. So in software development, one of our goals in supporting the system is to be predictable. And so we have regularly scheduled releases that we do in order to deliver fixes or improvements to the system. During a period like OE, where we're wanting to make sure that there's maximum quality going on in the system, we will deliver things like hot fixes, where we just focus on, instead of having like a set duration of time that we're going through before we deliver functionality, we just go as fast as we can to make sure that we make the changes necessary, get the testing done, and then deliver the fix to production to address any issues.
Is that helpful, Elliot? So basically, unscheduled rapid release.
Yeah, sometimes I find techie people have these terms and I don't know what they mean.
And I'm sure the tech industry feels that about health insurance. Thank you for asking the clarification, Elliot.
All right. So I'm now going to talk through the pain points we've observed in our first year with the system. And then I'll be talking about the solutions that we're going to be implementing to try and address these pain points. So first off, from a functional perspective, the dependent and spousal portion of the open enrollment wizard we found was unintuitive for users to use. Many users thought they needed to re-upload documents for their dependents, which they didn't. And in some cases, dependents or individuals connected to the users showed up in the UI when they shouldn't have. Regarding LTD, we found that that's not a necessary part of OE and it really shouldn't have been included, as it was creating additional complexity and confusion for members. For the daily sync process, in most cases, it's working perfectly fine, but it still produces errors and data issues in edge cases. An example of one of these would be the OE confirmation letters, which were sent out with 2024 plan information for some subscribers. And we're finding that significant staff time is spent addressing errors and cleaning up data around the sync. And then obviously, it can be frustrating for members and BAs, as Benefits 24/7 can say one thing, but then Pay1 is communicating something else to the carriers. Yeah.
Won't pick up too much, but I think, so I work at OFM. If there's a way we can connect to try and like collaborate to figure out how to make that transfer work better, because I know we feel the pain points on our end as well.
And then during OE, we saw that ERB ended up handling a significant number of calls from folks struggling with SAW or the authentication questions in the application, and it wasn't sustainable. Next slide, please. From an operational perspective, while we did vet the application before OE with ERB staff and with our technical teams, we failed to include benefits administrators or members. And we found, as we've dug into this, that the technical teams don't really have formal processes currently for capturing this sort of feedback. for vetting any existing functionality or validating any design assumptions for enhancements that we're looking at. We also, due to the work around Part D, as I previously mentioned, and Vision, we found that we were unable to fully complete stabilization to the degree that we would have liked. And this has resulted in an increased number of support tickets and slower resolution timelines for tickets as we balance competing priorities. And then finally, team resources have been stretched. The team has put in significant work and produced exceptional results to get us to this point, but they're extremely tired from the pace and the volume of the work. Next slide, please. So our roadmap for 2025 to address those pain points. We're going to be first focusing on stabilization, and that's going to involve working through the backlog of data fixes and defects that we have for the system. We're going to be prioritizing completing these with a goal of being able to transition towards maintenance and operations. Part of this is also going to involve setting up some focus groups consisting of members and BAs to provide direction and feedback for the changes that we'll be making. And the goal with this really is to get a feedback cadence established so that we can ensure that the application is staying customer focused and we're ensuring usability. Regarding the access issues, it's currently unclear to us what WATEC's timeline or implementation approach is for their SAW replacement, but it is clear that what we have currently in Benefits 24/7 is not sustainable. And so the team will be working with WATEC and other groups within HCA to identify options with the goal of being able to have a solution implemented before next OE. The team is also going to be investing heavily into automation. Most of the support processes currently for the application are largely manual, and this obviously increases the likelihood of errors and our dependency on key resources. The goal by pushing into automation is to recover capacity, address those errors or risks, and set the team up for future progress. And then finally, should the legislature approve our decision package, we'll be working on recruiting for the 10 additional roles across the team that it funds. These roles would significantly increase the team's capacity, reduce reliance on contractors, and our initial focus with these roles will be on recruiting around testing so that we can improve our reliability and capability in this space, which will be part of being able to finish out the stabilization process and transition the system towards a maintenance and operations posture.
Before we move on from that slide, or let's go back, stay on that slide for a little bit. A couple of things that I'd like to highlight. In no particular order, I'll just pick up where Clint left off about decision packages, staffing models, and those types of pieces. Because we just got finished a conversation with Robin talking about the state of affairs. And yet, I do want to share, and Tanya will go into a little bit more detail of this in her presentation. There is a decision package one of many decision packages that this agency put forward. There were very few that were related to the PEB and SEB programs, but this IT resource package or Benefits 24/7 package, because it's not solely IT resources, was the highest priority package for the PEB and SEB programs, and it fell in the top 5 decision packages ranked by the agency. And this agency typically pushes out around 50 decision packages in any given biennial year, just to give you kind of a sense of where being in the top 5 kind of giving some context to that. That decision package was partially picked up in Governor Inslee's proposed budget, funding, I believe, 9 FTEs, 6 of which are ETS type positions. And so I think it's important to highlight that even in the context of the state budget, the challenges and need to stabilize Benefits 24/7 and have appropriate maintenance and operations staff was seen as a high priority by the outgoing administration. We'll see how the budgetary processes go for the rest of the budget, biennial budget exercises, but we're hopeful that that recognition and importance of stabilizing the system for benefits for all employers in PEB and SEB continues to be a priority, because there are some additional resources that would really be desperately needed in order to right the ship on the resourcing of these systems. In addition to maintenance and operation, it would give a little bit of bandwidth to be able to tackle the list of things that everybody wants Benefits 24/7 to be able to do. I think all of us that have worked in the benefits area and used Pay One or rely on Pay One understand that there are many limitations to Pay One that are frustrating. For example, when Clinton earlier said that there's a daily data migration, He meant business days. Calendar days don't exist in our data migration system. So if it's a holiday or a weekend, that doesn't count. And there are certain things that have to be sequenced in a very deliberate manner. And it can take from the beginning process with manual steps that have to sync or reverse sync through multiple systems, easily 5 to 7 business days to go from the beginning of the process to generating a carrier file that gets that. And that's if everything happens in the perfect order of sequenced dance steps, if you will. And so there are a lot of improvements and a lot of user experience pieces. The ideas, we're not short on ideas for things to improve the system for either members or benefits administrators. And so our first goal is stabilize the system. What do we mean by stabilize? Things like we're back to typical customer service call metrics, call volumes, benefits administrator tickets, lack of reliance on paid overtime on weekends to process things, or overtime that's being utilized even if it's somebody who's overtime exempt. Some of those metrics that are classic indicators of we are kind of out of, we're back into kind of standard business as usual, working through a typical volume that the staffing levels are supposed to support. I think it is, I don't want it to be underscored too much. When Clinton had his bar chart at the beginning that highlighted there was this pivot to implement Medicare Part D and the standalone vision benefit, there had always been this idea, because there were tea leaves in the past couple of years teeing up that standalone vision was going to happen at some point. It was more a matter of exactly when, whereas the Medicare Part D transition was obviously a bit more of a rapid response. I know this board is very aware of the activity that happened in the last year to make that happen from the board's policy position. And we always tried to preview that it was going to be a very tight timeline. That was not in the IT pipeline. And so balancing the need and urgency for all the reasons that decision was made and needed to be implemented for the current plan year, with also trying to stabilize the system and finite resources. We're in the situation we are, where there's a lot of syncing issues between the systems that we're kind of cleaning up post open enrollment because of having to divide our resources. That's why, as we go into 2025, the first duty and priority is stabilizing the system, getting sync issues worked out, working on root cause issues, and truly kind of like stabilizing the system. The other piece is working on some interfaces that exist with the University of Washington and have been in the pipeline to develop for WSU, because right now we had to pull the UW, the way UW's system interacts with us. They currently still interact with Pay 1 instead of benefits 24/7. And if we want to proceed with things like generating carrier files out of benefits 24/7 instead of Pay 1, which eliminates the disconnect that is at least happening from the member experience of what they see in the portal versus what their provider or hospital system or the insurance carrier sees on their side, at least that piece would be cleaned up, but we can't get there until we move UW's system into interacting with benefits 24/7. Those are the key priorities. We don't have something envisioned or identified that would be of the scale of Medicare Part D or standalone vision. Of course, the legislature's in town, and we'll see if there's a project that develops from the legislative arena, but there isn't something else to detract from those stabilization and system work with some of the higher education institutions. And that's where our key focus is. If we are able to secure some additional resources, that will help us be able to stage things for improvements that many people have been yearning for and that our own agency is yearning for related to our system work. So I will pause for a moment. I see Elliot's hand. Go ahead, Elliot.
This is probably an evident question to you, but can Ferguson withdraw money from Inslee's budget that you requested to have allocated to these computer systems?
Every stage of the budget is a brand new document, if you will. And there is, I think we've all become accustomed to deference among different documents. And it's really, each document stands on its own. At this point, it's the legislature and the House and Senate are building their scaffolding of their state budget proposals. So far, Governor Ferguson has put forward budgetary priority documents that have a couple of key pieces. I don't remember them all, but a lot of it is the commitment to K-12, the ferry system, funding the collective bargaining agreements. There's a few key features, universal lunch in K-12. There are a couple of key features that are there. It's not clear if there will be another wholesale budget document produced by the new administration. It's as we're almost in February, it seems like the natural course of events is probably that the next budget document we see is either from the Senate or House after the March revenue forecast. But you know, it's going to be there is no assurance of something that either was or wasn't funded in Governor Inslee budget happening in the ultimate final conference budget that comes from the legislature. And so those are all conversations that will be had between the various leadership of the legislative chambers and the governor's office. So I think I think it's also important to say that that's always been the case. Just because something is or isn't funded in a governor's proposed budget, regardless of a change of administration, it is not de facto that the end result is those things will or won't be incorporated in the final budget passed by the legislature. Is that helpful, Elliot?
Yes, thank you.
Other questions?
I do have one more thing, Chair Ritter. I was like, another thing I wanted to go through, which is I wanted to make sure the board was apprised that we have pivoted how we communicate about benefits 24/7 issues this month. One of the Marianne Lindblad became interim director on January 15th, I think at noon. And by 3 o'clock, I briefed her on the IT systems and where we were with benefits 24/7, syncing challenges, and just general kind of incident response management that we're having after OE because of the volume of issues that were coming up. So it was one of the very first things that she was briefed on as an interim director. And in that conversation, we made the decision, and Marianne gave the direction to really beef up the outward communications that we have, both with benefits administrators and as we get to a point where we are able to do more targeted messaging to members who were impacted versus a broad communication that might overly concern people that don't have an issue within their account, because the vast majority of accounts are working as intended. That we also have some member communications. So we have committed to benefits administrators weekly communications of what is going on in the system. They're on Fridays. We've had 2, tomorrow marks number 3. We are kind of ramping up how we're doing that information, but we're trying to highlight in a more transparent manner some of the bigger issues that we are aware of. I think one concern that benefits administrators had is they weren't sure if we appreciated or knew of certain issues, and so us at least acknowledging that this is the issue that we see and how we understand the issue, even if it doesn't include the solution yet, just confirming for people and making them reassured that we are aware of various issues is an important piece of the communication. We're trying to tee up when we have potential solutions on certain issues, like when they are deployed, that we think something has been closed out. And then if a benefits administrator continues to see that issue, that they need to kind of alert us, because we will think that it is kind of that incident is over and we're moving on to another issue. We are deliberately trying to communicate an integrated information that might impact both. It's the same message for PEB and SEB benefits administrators, and it includes content of things that are being addressed that might impact state employees or higher education employees or school employees or retirees or internal workings of the healthcare authority, so that people are the totality of work that's going on. So we have committed to beefing up those communications. Right now, it is a weekly email. I have other pieces that we're going to work to deploy on the websites that the benefits administrators use to be able to kind of track things and have more awareness. And so I just wanted you to be aware that that commitment was made. It's something that is Marianne has conveyed as an important piece of righting the ship and helping develop and gain back some trust that has been tested in the last year with many of our key partners. And we understand and appreciate everyone's patience as we have been working through different pieces. But I wanted the board to be aware of that.
Other questions or comments? Then thank you so much. Appreciate it. So we're going to go ahead and break for about 15 minutes while lunch gets set up. So why don't we call it an even 12:10. I do have two announcements. One, Marianne will not be in today. Her engagement is taking longer than she thought, so I'll be hosting for the rest of the day. And I do have a priority noon meeting that I'm going to take. So I'm just going to introduce Kate and Tanya. They're going to go and get started at 12:10. I hope to be back by then. So Kate Walker, Policy Rules and Compliance Section Manager in the IRB Division, and Tanya Dool, IRB Finance Manager in the Financial Services Healthcare Purchasing Administration Division. That's the title. Are coming together to bring a legislative update as well as an overview of Governor Inslee's proposed budget. The materials behind tab number 6, and I will be back as soon as that call ends. Thank you.
Lou?
Oh, John, you have a question?
Yeah, I'm up in Alaska and having some difficulty with my internet. So if I come off, it means I just lost my connection.
All right, appreciate that.
Okay.
All right, this is Dave. Lou is still on his way back, but he teed up the next presentation already. And so we'll start with Cade. And again, we're behind tab number 6 in our books. So Cade, take it away.
Thank you, Dave, and members of the board. Cade Walker, Section Manager for the Policy Rules Compliance Section in our division. Here to provide you an update on the legislative session that just began a couple of weeks ago. So I've got some slides. If I can pop up here. We'll hop right in and I'll provide some additional comments along the way. So just as a starting point, I always like to begin by reviewing the kind of the quantity of bills that are coming in that are impacting or that we're taking a look at. And actually, this is current as of Friday last week, and this week has been quite the explosion of additional numbers of bills coming through. Well, it was at 55 as of Friday last week. We're now up to 103 this week. So we saw a massive explosion of the number of bills come in just this week as opposed to all the pre-filed bills and everything else. So cranked up a lot this week. In fact, I've spent all morning during this meeting reviewing legislation, reviewing analyses that have been done, and trying to get those processed so we are being able to be responsive to the legislature and to our authorizing environment. Just by say here, so just as an update of how we do our analyses in-house, this matrix makes up kind of how we review and take a look at all the different bills that come through. First, we'll take a look at the difference we have between our lead and support. HCA has a lot of different work streams, a lot of different divisions that provide expertise and analysis to the legislation that comes out. Sometimes ERB, our division for employee retiree benefits, is the lead, meaning that we're going to be the one that supposedly has the most impacts from legislation, or that we're the ones tasked with making sure we're tracking it and compiling all of the input that comes from other divisions in the agency. And oftentimes we are a support division where we're not necessarily the lead for it, but we're going to provide our perspective from our program standpoint and then provide that to the lead division who's doing that analysis. So that's the first split we usually have with legislation, whether or not we are going to be the lead or the support. Then we'll split up the bills that we get assigned to us based on a high priority or a low priority. What this entails is the analyst who gets assigned the bill within our division for review will go through and make a determination based on their expertise about whether that legislation should be considered a high priority, low priority. Low priority, high priority for us really indicates that there's going to be a potential change in benefits. It's going to change something, the way that our carriers do any sort of administrative aspect. It might have a cost that comes to us, something that may cause us to have to change up any of our rules or policies. So we're looking at factors that are going to actually, something that we're going to have to take a look at and implement in the future with any of these legislation. The opposite of that, the low priority, would be the absence of those things that we're going to keep an eye on. And we're going to be watching and seeing what might evolve. There might be an amendment that comes out that changes that from a low priority to high priority. We're going to be tracking it. And the difference in that for our analysis really is the time and depth that we go into. These analyses take our analysts significant amount of time to review, and it's in addition to their current workload. So when we are conducting bill analyses, we try and make sure that we don't overly inundate our staff with having to do more bill analyses than is necessary, just to make sure that we're able to keep them free to be able to pick up things, because these bills come out and we have a pretty quick turnaround time to get them assigned, reviewed, and then back out to make sure we're able to provide feedback to our authorizing environment and to legislature. Also, just lastly on here, fiscal notes. We highlight these because it does take an additional amount of work for our staff to do those, to then also coordinate with our financial services division, Tanya and her team, to make sure we're working well with them to provide narrative and information for them to be able to conduct the financial analysis that bills would have. So while we're up to 24 here, I think we've had several more come through this week. So this week has been a very busy week for us and the legislature, and the number of bills coming out that have potential impacts to our programs. With that, we'll go to the next slide. Before I talk about this briefly, I just want to make sure I thank all of our analysts. That slide really is the work of, shows the work of our analysts. We've got about 35 analysts within ERB who have on their job requirements under other duties assigned to take up bill analyses. And it's always hard to predict where those loads will land based on individual subject matter expertise. But our subject matter experts that we have within ERB that do these bill analyses have done just a fantastic job in the first 16 days of session with the workloads and everything we have going on coming through at the end of open enrollment and all the work we do. They really do a fantastic job. So I just want to make sure it's my appreciation to all of them for the work they do. It makes my role as the division coordinator a lot easier, knowing that I've got a great team of people who are doing those bill analyses, who are really smart and thoughtful, who coordinate their reviews. They get in touch with our carriers and our partners and provide great input and analysis on the work that the legislature is putting forward. With that, this is our funnel that we put forward every year to kind of show where legislation is that we're tracking that's a high priority ERB impact legislation and where it's at in its process. As you're aware from Schoolhouse Rock, there's a lot of steps for how a bill becomes law. And this is a little bit of a diagram to show that for how it becomes a law in Washington State. It has to first pass through a series of chambers in the House of Origins, usually goes through a policy committee, then it will go through the fiscal committee, which will either be the House Appropriations or the Senate Ways and Means Committee. Then if it passes through those committees, it will go to the chamber, it will hit the floor, and then it will get voted on by the entirety of either the House or the Senate. Then it flips that to the opposite chamber, goes through that same process. And if there's consensus at the end of those 6 votes, then it goes to the governor's office for signature. Right now, we're still really early in session, so we've only seen one bill so far that's made it out of, been voted on in a chamber policy. So the dates on the left show you those cutoffs. The reason those cutoffs are important because a lot of legislation gets introduced every year, and just like a funnel, it starts to weed away things after each of these votes at the different chambers. So the dates are when those pieces of legislation need to be voted out of that particular step in the process in order to be considered still alive or an active piece of legislation. Otherwise, we call it dead, and it's dead until the next session, this year at least, or it is dead and then would need to be reintroduced when a new legislative term starts every other year. So this will get more filled in at our next meeting as we probably get through at least the first 2 cutoffs for legislation, and that's the first swipe of really seeing what is moving this year and what is not moving this year. Next slide, please. So just to back up a little bit, I want to go over a couple of legislative reports that were requested of us to produce last year and that we have written, stakeholdered, and had approvals, and now they've been published. So I want to just quickly go over those 2 reports. First, there is, and both of these reports came from budget provisos. There's a couple of ways in which we can be requested to do reports for legislature. One might be that there is legislation that is passed, policy legislation that says they want to have a report done by an agency on a particular topic. The other way that they can do it, which is the case for these 2 reports, is that they have a budget proviso that provides funding and says, HCA, go and write a report on these few things. So that's what happened this year is we had two budget provisos that asked us to conduct these 2 reports and publish them the 1st of December. The first report I'll go over is on anti-obesity medications, or AOMs, in the Uniform Medical Plan. A copy of that report can be found at the hyperlink that's listed there. It's also available on the legislative website under legislative reports. Look and sort that by HCA and see reports. There's a lot that have come from HCA, just 2 that have come from the ERB division this year. The primary recommendation from that, the report was asking for recommendations and how much it would cost for the plan, for the Uniform Medical Plan to cover anti-obesity medications. I think this largely came about because of the high interest in what are called GLP-1s or semaglutide with its name brand of Ozempic or tirzepatide or other those injectables for weight loss. So there was an interest in saying what would that cost and how would there be kind of a protocol for accessing that to our Uniform Medical Plan. The recommendation from our report was that there would be the use of prior authorization with a particular cadence that would ensure that those who are seeking it are able to get it when there is medical necessity for it, and that there's tracking to make sure that in the event that it is being prescribed, that it's being well tolerated and that it's being effective, because the cost of those medications, as you see in the next bullet, is pretty substantial. Now, the estimated increase in employer medical contribution, the EMC, that Tanya could probably go into more, but this is for the entirety of the PEB and SEB programs. The range of costs, depending on what criteria would be used, was estimated between $129 and $260 million per year. That's cumulative for the PEB and SEB programs for both the fully insured and self-insured health carriers. So a substantial amount of money to cover that, and so we put that report forward. Now, there has been legislation that has come up, been introduced, that relates to anti-obesity medication. I'll speak to just in a minute, but just wanted to call that out, that there is interest in it from the legislature, but that financial amount to cover it is such that it probably makes it a pretty complicated bill to move forward, given the cost of the state and the budget situation that we're currently in that we heard about earlier today. The next report.
2 things before we move on to the next report. Just to highlight that the agency was having a recommendation in the context of if the legislature chooses to go down the road of covering the drug. So we weren't tasked as an agency with chiming in on whether coverage should happen or not, but if coverage happens, then what is the recommendation? And so just wanted to put a very fine point on the narrow nature of the question that was presented to the agency. And the second piece is just to highlight that this last bullet is describing cost for the state's side of the employer medical contribution. So the EMC is the embodiment of the collective bargaining agreement's 85-15 split, and it is an 85-15 split in both the PEB and SEB programs. So there is a other side to that equation, the impact on the employee premiums. That would be that, the employee 15% side of the equation. So just wanted to highlight that most costs wouldn't be covered by the state. It would be baked into the EMC process, and there is a 15% allocation in that math formula that would trickle over, or not trickle, it would move into the employee premium side of the equation. So just wanted to highlight that too.
Next slide, please. So our second report that we had that this board is aware of is the study on the consolidation of the PEB and SEB programs in their entirety. Now, the request from the legislature came with 3 primary aspects to it of what consolidation, what we would conceptualize consolidation looking like. First was having a consolidated board, so taking the PEB and SEB boards, combining them into a single board. Second was the consolidation of the non-Medicare risk pools. If you recall, there is a risk pool for all of those who participate in the SEB program. Then in the PEB program, there's 2 risk pools that are differentiated between those who are Medicare eligible and those who are not Medicare or non-Medicare. The consolidation was for the consolidation of the non-Medicare risk pool from the PEB program and the risk pool from the SEB program into a single non-Medicare risk pool, leaving the risk pool for the Medicare retirees untouched. And so there'd be two risk pools under the consolidated program in that way, combining it from the 3 that currently exist between the 2 programs. Lastly, there would be a combined solitary benefits portfolio with the benefits available to the entirety of the populations under that one program. Also critically, it was requested that there would be no eligibility change for all of the populations in either the PEB or SEB programs, whether they're active employees, retirees, COBRA. There's a lot of different types of employee eligibility criteria. And so the legislature requested that in the conceptualization of what consolidation would look like, that we would ensure that all the eligibility remained the same. So there's not going to be any individuals who would unintentionally gain or lose eligibility for the program as they currently do. We would carry forward all of the rules and policies and laws related to eligibility. And the last point I have here is that as part of the report, and it is included in that report, which is hyperlinked above there, they did ask us to provide all the statutory changes that would need to be made to necessitate, to effectuate the changes asked of in that proviso. And so we did include that. Now it's substantial. And so in the report, when you click on the report, you'll notice it's about 50 or so pages. The full list of the statutory changes that were suggested by us was included in the appendix. It's a hyperlink because it's about 70, 80 pages of really wonderfully fun to read statutory amendment language, a lot of strikeouts and rearranging and structuring so that we would have all of the types of changes that would be necessary for the type of consolidation the legislature asked us to conceptualize could be done that way. So we did provide that, and that's included in what we did. And I mention that because there is legislation that has been introduced in both the House and the Senate for consolidating the PEB and SEP programs, which they did use our recommended statutory changes as kind of the basis for them to draft that legislation, which I'm glad they did, because if they had gone forward, we are the experts, me and my team and our division were the experts on all the statutes related to PEB and SEB. So letting us help make those changes and provide that to them, I think makes pretty good legislation. We got it mostly right. We have some amendments that we have proposed that just help clean up things and some references to other statutes that are included. But having 80, 90 pages worth of statutory changes is quite a workload. And being able to do that this summer as part of this report, I think helped made us good partners with the legislature when it comes to this work if they're going to move forward with it. And we'll talk about that, I think, that in just a minute. So I'll pause and see, Dave, if you have anything you want to add there. Okay. Moving on. So now we'll talk about some of the legislation that we're seeing. First, we'll start with some of the agency request legislation that we have put forward. So every year we have the opportunity to draft legislation that will help make amendments to our program. Sometimes it's more clerical, administrative changes. Sometimes it might be some policy changes we're looking for. This year we have one piece of legislation that's coming from our division directly, and another piece of legislation that's coming from the agency's policy shop that is intended to make some changes for the PEB and SEP programs. That legislation is that I was just referring to, House Bill 1123, Senate Bill 5083, titled Ensuring Access to Primary Care, Behavioral Health, and Affordable Hospital Services. This is a bill that's intended to try and increase access and reduce some of the contracting concerns that have come up in the past few years, I think some of which were discussed with our panel earlier, that our policy shop had introduced, has some pricing aspects in it to try and statutorily define how contracting can be done and trying to ensure better access for our members and hopefully taking out some of the consternation that comes about when there's contracting concerns between provider groups and our carriers. The other piece of legislation we have that is coming from us is Senate Bill 5478, and I think it has a House bill that's come out for it so far. Maybe not, but this is coming from us. And the background on this PEB board authority is that in 2020, when the SEB board was created, we became aware that school districts offer a whole plethora of different types of benefits to their employees, benefits that we don't offer through the SEB or the PEB program, that the districts had expressed a lot of interest in continuing to offer, and also with some concern that there might be some competition between the benefits they were offering and our portfolio of benefits we offer. So 2021, we had legislation introduced for the SEB board that defined a list of 10 ancillary or supplemental benefit types that could be studied and offered by the SEB board and provided to employees on a voluntary and employee paid basis. These were benefits like cancer insurance or hospital confinement insurance, pet insurance is on that list, legal aid, additional property insurance, a few, there's a few of them that are listed, and that was passed in 2021. It also allowed the districts to provide those benefits as long as the SEB board wasn't offering. But what we then realized pretty quickly as well that the PEB board doesn't have that offering authority, and PEB is only allowed to offer benefits that it's authorized to provide from statute. And so this legislation 5478 takes that list of benefits that the SEB board currently has authority to offer and grants it to the PEB board, so that if the PEB board so chooses and there's available funding for the administrative side of those benefits, that the PEB board could pick up some additional supplemental benefit types and offer them to members, things like pet insurance, which we will see OIC starting to do more regulatory work on pet insurance, those other types of insurance that I mentioned. So we're tracking that. Thank you to Senator Bateman for introducing that for us, and we're keeping an eye on that. And I think we expect that will pass pretty smoothly. I also want to note that I'll speak to that in a second. Next slide, please. Dave, anything you want to add?
Nope, just woe is the person who predicts the outcome of the legislative process. Simple little bills just sometimes get caught up in timing. Sometimes, so.
Yeah, what I was going to mention on that is that so now we're to House Bill 1330, 5086. This is the legislation that's not coming from the agency. This is legislation we're keeping our eyes on. In fact, there's a lot more that's come out this week, and I'm just speaking of the highlights this week. This meeting, having grouped categorically in some of the bigger buckets of things, just to try and organize them for my own mental sake here, because there's a lot of number soup otherwise. So kind of on the administrative side of changes of legislation that we're seeing, first and top of the list is House Bill 1330 and Senate Bill 5086. That is a legislation that would, if passed, would consolidate the PEB and SEB, if passed in the current form, would consolidate the PEB and SEB programs into a single program. The legislation calls the new board the WERB board, the Washington Employee and Retirees Benefits Board. And so that's going to be a fun opportunity for our communications team to come up with how to market that a little bit and come up with something there. In that legislation, they have, again, as I mentioned earlier, they've taken the backbone of our statutory changes that we made as part of our report and used that to move forward with creating legislation that has now since been introduced. It's being heard at committee today on the Senate side, today at 4. So if you're interested in hearing on that, it will be on 4 on TBW. It does also take for the consolidated board authority, just a couple of points on that, given that I'm speaking to one of the boards today that would be consolidated. The timing on it would be that the consolidation would be effective for the 2027 plan year. So the new board would be convened, it would be appointed by September of this year, with the new board needing to start its work almost immediately to be able to then have a portfolio of benefits that would be put together and voted on by the board effective for the 2027 plan year. So they spend all of the rest of 2025 and first 2026 getting all the benefits and everything that the board would need to do work-wise voted on, so that the program would go into effect as a consolidated program and a consolidated portfolio of benefits effective 2027. The new board would also have that expanded authority for supplemental benefits that I spoke about earlier, about our agency request legislation. So it almost would become a bit of a moot point on our agency request legislation if the consolidation were to move forward, because that language is also assumed in the consolidation language that's being put forward. It doesn't touch on a couple of areas like collective bargaining. There isn't any aspect of the consolidation that touches on collective bargaining. That may be something that has to be looked at and understood a little bit more in the future. But the assumption would be that everything would move forward as is currently. Let's see, David, are there any other aspects of that legislation that you would want to speak to?
When we left off in the board season last year, briefing the board about the structure of the report, the legislative report did include multiple options for the composition of a future board. And there were 3 illustrative examples. There are obviously many ways to constitute a board. And that was one of the pieces where the statutory language in the appendix gave options, the choose your own adventure book, if you will, depending on, what, if somebody would draw up a bill. The version that is pending before the legislature right now is the version that has a 15-member board, 6 that represent various populations within the program, and 6 that are thought of as the health policy experts, administrator side of the equation, and then the 15th person being the director of the healthcare authority. 13. 6 plus 6 plus 1 is 13, not 15. So thank you for math correction. For the 6 positions that represent various employee of various populations, 2 retirees, 1 from K-12, 1 from state agencies, kind of like today, Tom and Elliot position, if you will. 2 positions related to state agency or state employees, one for state agencies and another for higher education institutions. So the most analogous today is the state agency type position is similar to your current position, and there is no equivalent today for a higher education version of CURT, if you will. And then the other 2 positions, school employees, one for classified staff, one for certificated staff. So that's the 6 that are on that side of the equation. Within the 6 that I described for health benefits, policy, administrative, cost containment, all those magic words, there are a couple of spots that are more specifically designated. So for example, state HR director or their designee, aka Michaela's position currently, the director of the retirement systems or a designee, position related to with expertise on health equity, and then a position that is designated for business administrators of school districts, which is the organization called WASBO, and that has an equivalent seat on the SEP board. The other 2 spots of the 6 don't have specific requirements associated with them, but there's just, I wanted the board to be aware of kind of the structure that is in that bill, and a little bit of how it relates to positions that all of you on this board are in currently. Kyla has a question.
And you may not be able to answer it, but like theoretically, if this bill passed and they moved towards this way, what would be a law, like a estimated implementation timeline? Like, would it be next year or would it be longer than that?
The launch of the single portfolio for a single program for benefits under the bill is 1/1/2027. So a board consolidated board appointed by Governor Ferguson this fall. The rate setting process that would be happening in 2026 would be for a single suite of plan presented to that board for setting of premiums and authorization. That would then be the fall 2026 open enrollment for go live in 2027. That's all I wanted to add. Was a little bit more about the board composition, because that's definitely speaking to one of the 2 boards. I'm sure you would want to know that level of detail. So that is what was the version that was selected by the sponsors of the bill. Okay. Oh, there's a question from John Comfort.
Yes. Is there a non-voting member as part of that group?
I'm glad you asked that question, because I was just looking through it. I was like, I took everybody but John. No, there is no non-voting member included in the bill. It consolidates and does not include any non-voting participants.
Thank you.
Moving on, some of the other administrative pieces of legislation that we're tracking, House Bill 1069, 5044 in the Senate, allowing collective bargaining over contributions for certain supplemental retirement benefits. This is allowing for active employees to be able to retire for benefits that would be available to them in retirement. And so we're going to track that and see. It doesn't have a direct implication for our programs, but we'll be interested to see if this allows and that authority does come forward and they have the opportunity for there to be active employees being able to bargain for benefits that would be available to them in retirement. House Bill 1354, always like to make sure I mention any time there's going to be legislation that would expand some eligibility to a population that currently isn't eligible for PEB benefits. This legislation would expand eligibility for PEB to those who work seasonally for the during the legislative session. So all the staff who are up there who aren't employed full-time through the year, this would create eligibility for them to be eligible for PEB benefits for the duration of the year in which they are alleged staff. So always good to see an opportunity for more people to have access to PEB benefits. House Bill 1312, Senate Bill 5114. This is a piece of legislation coming from the Department of Retirement Systems. This is legislation that was introduced last year to ensure that when a retiree who is enrolled in a DRS plan passes away, that at the month of death, they are paid the full amount of their monthly retirement, as opposed to the prorating that's done currently. This was introduced last year, and then there was some additional language that was added to it that said that for retirees that pass away mid-month, that the premium that they owe for their benefits for the month of death would be waived, so there wouldn't be a loss of coverage, which was happening because of the proration of benefits. DRS clause back payments that were made on their behalf, which oftentimes includes the payment for their benefits. So that while that provision did pass last year, that the PEB program is allowed to waive the premiums for retirees at the month of death to make sure that they don't have a loss of coverage. This portion of the legislation last year about the month of death for their full pension being paid out did not pass. So now this year, this legislation has been introduced again, which would have a potential impact for us if they wanted to then reverse the language that was passed last year about not needing to have the PEB program waive their premiums anymore, because now they wouldn't have to be doing the clawback for their premiums. So this was not a huge impact to a lot of people every year, but it was certainly, for those that it didn't impact, it was certainly real cumbersome for them and problematic when they have cancellation of benefits, especially where in the month of death they likely have some pretty substantial bills that come about from that. So we don't have an official position on this legislation, but we're keeping an eye on it because we would like to make sure that if there's the opportunity for us to save some money and not having to waive premiums for individuals, that we would like to make sure that is something we're keeping an eye on and put forward if needs be. Dave, anything on that?
Just that I believe technically it's Select Committee on Pension Policy legislation, which DRS shepherds. I don't think it's technically DRS legislation, but splitting hairs.
What we do best. On the provider side, we have House Bill 1124, 5112, prescribing psychologists. I kind of like this one. I like this one just from a standpoint where it allows psychologists who are not medically trained, have an MD, to have some prescribing authority that would be provided by license from DOH, that they'd be able to provide certain behavioral health medications as a psychologist, not as a psychiatrist. So expanding the ability for us to address the behavioral health crisis that we're still facing these days, and allowing greater access to care for psychologists and for our members. There's House Bill 1114, which would include us in the multi-state respiratory care compact, allowing Washington to recognize the licensure of respiratory therapists from other states and vice versa. So we're able to provide greater, have more access to respiratory therapists, especially in our areas that border other states. Next slide, please. Moving on to health plan coverages. There's been a lot that's been coming through so far. We have House Bill 1062 again, that the policy coming forward again that has been introduced the last couple of years regarding coverage for biomarker testing. We've seen quite a few pieces of legislation related to women's healthcare services. House Bill 1090, contraceptive coverage, which would allow for initial dosing of contraceptives to be at a 12-month interval rather than it just being on refills. That would be a 12-month interval. House Bill 1129, 5121 related to family-related services, fertility-related services that would expand significant amount of coverages for infertility treatment, diagnosis, and preservation services under that. Yes.
I just remember last season we had someone come and speak that gave like a very moving. Would this help address what they were kind of talking about?
Yes, and I actually read that PEB member testified at the policy committee in, I think, the House heard the bill. Yeah, I think so. And she's let me know about that, and I've made sure she's aware of the legislative process and that there's many opportunities to testify during the journey of a bill. But yes, she's been engaged, and I believe that it would address at least the general topic that she brought to the board.
Then there's also 5075, which would remove cost sharing components for certain prenatal and postnatal care, helping with access, but also helping to lower the costs for those services for women under any of our plans and for anyone in the state of Washington. There's also been legislation related to the dental insurance practices, trying to align some of the administrative costs and split between payment for services and administrative costs from an 85-15 split that currently exists for health insurance to the dental industry, having some other components that would mirror similar to health insurance requirements, applying those to the dental industry, dental insurances. House Bill 1326, 5353, as I mentioned a little bit earlier, this is legislation that would require carriers to cover not only medication treatments, but also surgical treatments for diabetes and obesity treatments. So we would we're keeping an eye on that. We're going to keep an eye closely on that and see. We know the cost on that would be substantial for the medication and treatment for obesity. Currently, our plans do cover medication and surgical treatment for diabetes, as well as surgical treatment for obesity, but it's that medical component requirement that would have has a hefty fiscal impact to our programs. So we'll keep a close eye on those. On the pharmacy side, always quite a few pieces of legislation regarding pharmacies or pharmaceutical industry and pharmacies and medication. 1186, medication dispensing, allowing for hospitals to have greater emergency rooms to have greater dispensing authority on the types of medication they're able to provide to patients who are seen in the emergency room. Senate Bill 5019 related to allowing there to be certain prepackaged medications to be made available to the public that would have larger supplies than 90-day supplies for certain types of medications. And then 5326, this is legislation we did see last year as well, that would require the healthcare authority to establish an emergency insulin supply that would be available to the public in the event that they are without insulin due to any number of factors, but it would give them up to a 30-day supply of insulin that they would have. They would be provided free from the healthcare authority if that were to pass. Next slide, please. I think that's it. All right, with that, I'll be back at the next meeting to provide a lot of updates about things that have happened in the duration. Well, I think by the time we have our next meeting, we'll have had a couple of cutoffs, so we'll know a lot more about what pieces of policy are moving forward or not. So we'll look forward to providing updates then. Any questions?
Any additional questions? Tom, see your hand.
I'm sorry, did you call me?
Yes, sir.
Okay, Cade, I have a couple of questions. So the anti-obesity, I read that report and the recommendations, and prior authorization. I've noticed in a number of letters that we've received over the last year, people having a lot of problems with prior authorization and denial of authorization for, not related, of course, to this, but to other things. So I'm wondering, who would be the deciding group or panel that would decide whether to grant? Does that report address that?
Tom, I don't know that the report itself addressed that. What I'm going to ask is, we're actually working on a presentation for the March board meeting about prior authorizations and implementation of House Bill 1357 that passed last year. And I will ask the team that's working on that presentation to kind of incorporate some principles related to the question that you just asked, if that's okay.
Okay, and then also on the consolidation of the PEB and the SEB, I noticed I don't mean to get ahead on Tanya's presentation, but she is going to talk about increased costs to switch to a Plan B and the costs that will entail in making that transition. I'm wondering if there is also going to be some cost to startup costs. If we were to go to the consolidation of the SEB and the PEB, will there be, or have they included in the study, the possibility of costs that would have to be borne by that consolidation?
Tom, we kind of lost you in the beginning of what you said. Your opening comments.
Oh, okay. So the proposed consolidation of the PEB and the SEB, when I looked at Tanya's presentation, I noticed that she is going to talk about the startup costs for switching to Plan D, and that there are costs to make that transition, and that's included in her presentation. I'm wondering if there are going to be similar costs were we to make a consolidation of the PEB and SEB, and if that has been considered in the proposal that the legislature is looking at.
It's Tanya. I think you're talking about when I walk through the decision packages, the increased cost for our third-party administrators, so Regents and MODA, and how some of that cost was associated with the start of the Part D for our Medicare members. Is that what you're referencing?
Yeah, on your slide 4 and slide 8, given budget projections about the costs to switch to the Plan D formula. And I'm wondering if there will also be startup costs to switch to consolidate the PEB and the SEB.
Tom, this is David. I think if I'm understanding that question right, so please let me know if I'm not. I think the short answer to your question is no, and the reason that I think that is we're serving 700,000 covered lives today in 2 different programs, and under the bill that has consolidation afterwards, we'd still be serving 700,000 individuals. And although we don't know exactly what plans would be offered, and the report has to make some assumptions based on to model anything to give some sort of illustrative examples as to what could happen. It's not a precise analysis because it can't be precise because we don't know exactly which plans will be there, but we would, I think, model it and assume a similar level of enrollment in the self-insured plans. But the TPA, the third-party administrator accounts that are administered for the programs are intimately tied to enrollment in those plans and have historically always been trued up by the legislature to account for variance year over year, whether that's up or down. Though historically UMP has grown in its membership in most years, has had net increased enrollment, but those accounts are giving the agency the authority to pull from the main program account. It's not really new money that's an expenditure. So in general, not really a cost increase that gets attributed to the general fund in some way. Tanya, do you want to add on to that?
I think one other point tying to your question, Tom, is that the work that Regents and MODA already do for the 2 programs already have existing rates that are set for those 2 programs, and they are the same. They're really backed by the same contracts, whereas the Part D work was actually new work that MODA had to do to administer the change to Part D. So the fees did change. So under consolidation, we don't anticipate that the Regents and MODA per subscriber per month fees would change under that consolidated world. Did that help?
Yep, that answers my question. Thank you.
Any additional questions? Okay, thank you so much. Tanya, welcome.
Thank you. I've already jumped in here a little bit, so I'll just say for the record, my name is Tanya Dool, and I'm gonna give a quick update on Governor Inslee's budget. I want to pause here for just a second and just tie a little bit of a bow on this by saying this is based on Governor Inslee's version of the budget, which came out in December. This is not reflecting a full version of a budget by Ferguson. Like Robin mentioned earlier, there are some priorities that Governor Ferguson has announced, but this presentation that I'm going to walk through today is strictly based on Governor Inslee's version of the budget from December, and will likely have changes and edits to this version as we see a House and a Senate proposed version of the budget. The first up is just a little recap on the timeline of the budget setting process. So we start really in the summer, and it starts right here at the board where we have ideas that come from the public, from the board, from our health plans, where we start evaluating options, and largely these can come throughout the year, but we really start putting pen to paper in the summer and drafting up and modeling those budget requests. Those get sent over to the Office of Financial Management in the fall for consideration in a governor's proposed budget, which usually comes out, right around the Christmas holiday. And then session starts beginning of January. So throughout session, we will be monitoring various versions of the budgets proposed by both the House and the Senate. Session is expected to end, hopefully, at the end of April, where we will have a final conference budget where the governor will have an opportunity to look at vetoes. And then we would bring back to the board, hopefully right after that, the final version of the budget. So again, all of that to say, a lot can change between what I'm going to present today and May. The first step, we're going to do a little pit stop in a supplemental budget. As a reminder, when we go into a long session, which this is in the odd years, we have to consider both a supplemental budget and a biennial budget. A supplemental budget really gets us through the end of this current fiscal year, so June 30th. So any funding that comes out of a supplemental budget at the end of April would just be for those next few remaining months through the end of June. So they're really cleanup in nature for the purposes of PEB and SEP budgets. So on the next slide, the first one is kind of what we were just getting into with the question from Tom, which is our third-party administrator or TPA spending authority. These are our administrators for our self-insured medical and dental plans, so UMP and UDP. On the medical side, we have contracts with both Regents and MODA to administer the medical and pharmacy side. And then on the dental side, we contract with Delta Dental to administer our self-insured dental plan. Each year, as open enrollment ends and members switch throughout the year, we look at the enrollment patterns within each of these plans, and we have to project what we need in order to be able to pay our TPAs throughout the remainder of the year based on the enrollment within those plans. So for the supplemental budget, we need an additional $1.5 million to get us through the end of the year to pay our TPAs. This largely had to do with changes in our self-insured enrollment. So as you all remember back in plan year 2024, Kaiser did have some pretty significant rate increases, which did drive a big amount of members switching into our self-insured plans. So we're catching up with some of that spending there. And like I mentioned just a few minutes ago, with the transition for our Medicare plans to Part D, we did have some increased fees with MODA. That also has to be paid for out of this budget. So this is just spending authority to align with our projected costs out of these accounts. On the next line, we have contract increases. We contract with an actuarial firm to help provide some of our more complex analytics and rate setting. That work has really increased and gotten complex over the last few years. And over the 10 years that I've been in this role, we have not increased our PEB work order budget for our actuaries. So this is an increase to help support that additional workload and cost that comes out of that budget. The next slide, we're going to start walking through the biennial budget transition over. We're first going to look at the collective bargaining agreement changes. So each even summer, the healthcare authority, there's a few of us that help support OFM and statewide HR in negotiations for healthcare benefits. We support some of the modeling and some of the implementation of some of the healthcare items at the table. And there's a tentative agreement that is up for funding in the legislature. And what that includes is maintaining the 85%, the EMC at 85%, benchmarked off of UMP Classic. It codifies the vision change that employers will pay 100% of the standalone vision costs. And there is a medical FSA benefit that has existed within the collective bargaining agreement where certain members, based on their salary and benefits eligibility, receive a contribution from the state into their flexible spending arrangement. This benefit is maintained, but it changes the salary threshold up from $60,000 to $68,004 annually to keep up with some of those general wage increases. And it also increased in this agreement from $250 to $300. What we really looked at when modeling this is maintaining some of the same number of eligible members from the inception of this benefit and maintaining that those same number of members would be able to maintain this benefit throughout this next agreement. So this agreement will become final once the legislature funds this in the final conference budget.
A couple of things to highlight. We won't go through all the eligibility requirements for the medical FSA, but I do want to highlight that it is only available to represented employees. This is not something that is available to non-represented employees. The other piece, going back to Kate referencing one of the best things we do is split hairs finally. I do want to, I think it's an important nuance just to remind people of is the bargaining table HCA supports and provides technical assistance and insights to the governor's office at OFM. Sometimes people say that the bargaining is happening with HCA. It's happening with the representatives on behalf of the governor's office, and HCA is in a supporting role to the governor's office at OFM. So just like to put a good fine point on that too.
So next up in the biennial budget are the biennial versions of the decision packages. The first two are the same concept as the supplemental with just additional dollars, because instead of getting us through the end of a current year, these are over the next biennium. So the first one being our third-party administrator spending authority. So again, this is to align with our enrollment within our self-insured plan and those increased fees associated with the Part D plan at $17.3 million. The next up is contract increases biennialized out for the whole next biennium at $700,000. And then the third one on this list is something that Clinton and Dave talked about a little bit earlier, which is our IT resources decision package. This decision package is actually a combined package between the PEB and the SEB program. There were a total of 9 FTEs that Dave mentioned earlier that were funded within Governor Inslee's version of the budget. 5.5 of those attributable to PEB program funding and the remainder to SEB program funding. And I just want to highlight that there is a little bit when we do these joint packages where a portion of it is more heavily weighted to the PEB program because of the need for retiree support. So because Benefits 24/7 also supports our retirees, some more of this is more weighted to the PEB program. We don't charge SEB for the PEB retirees. And I see, Harry, you have your hand up.
Yes, I do. And I'm sorry, I know we'd like to wait to the end,
Okay.
but I know this is going to shift a little bit in the next few slides. So I'm a little confused, or maybe you can clarify for me the TPA spending authority, uh, increased self-insured enrollment. I don't have the numbers in front of me. But when we went through that before about the shift, it seemed to me that there was a net decrease in the self-insured, the UMP. So I'm a little interested, interested in that. The Part D transition, I understand that I grasp that. So can you, I mean, not reassure, but give me a little bit more information what this means about increased self-insured enrollment, unless maybe I've read the data wrong, or there's a more context to it that I'm missing. Thank you.
So Harry, it's not just limited to the transition that you saw that was presented earlier for switching for 2025. It also includes switching that happened from 2024. So depending on where we are at the time of requesting funding and what our account balance looks like at the time, we don't always align perfectly to each open enrollment. So this is reflecting changes in the medical plan, the dental plan, and the Part D fees throughout the last 2 open enrollments, if that makes sense. So it's also our non-Medicare population, so our active state employees, where a majority of this is really attributable to the Part D fees. The rest of it is the non-Medicare switching that occurred over the last 2 plan years.
Got it. Thank you.
If you go back to the slides that Alyssa had earlier in the presentation and did the net effect of the various UMP plans in the non-Medicare risk pool and the UMP Classic Part D plan in the Medicare, you would get a net increase of about 3,000 subscribers. And so even this last open enrollment, the net increase of all of the changes across the 2 pools that is attributed to the UMP portion, even just in that slice, there was a net increase this past after the results of this past OE.
Appreciate the answer. Thank you.
Yeah. All right, I'm going to slip to the next slide because I think, Dave, you covered the rest of the IT package earlier. So first up on this next slide is we had a decision package focusing around some benefits enhancements, where 2 of the smaller items were picked up within Governor Inslee's budget. The first being funding for doulas in the Uniform Medical Plan. So currently, doulas are not a reimbursable provider type within the PEB or SEB Uniform Medical Plan offerings. So this funding would allow for coverage of doulas over the next biennium. I do want to note that there are some operational challenges that we're working around. So this is not set in stone that we will have doulas covered over the next biennium, but the funding is available if we can get this done. And we will talk more about this as we move into procurement and the benefit design and the rate setting process later this year. The second one is funding for some dental benefit enhancements. You know, we have talked about these for quite a few years, and two of the more financially smaller items were funded within this version of the budget. And that is removing the deductible for children under the age of 15 and increasing the TMJ budget. These, I don't want to minimize that these are small, because $760,000 is still, you know, a lot of money, but in terms of program costs and what it takes to increase our funding, these are relatively small for our scale of a program.
And I think the important piece about the size relative to the funding rate is the totality of these two things does not require an adjustment to the funding rates. So when they are of this relatively small size, it's more about everyone being on the same page that the authority is there for being able to pay those claims and without having to make an actual funding adjustment. So these are really about potentially having express authority to make these changes. And maybe I should say, not too fine a point, to back to Robin's presentation from us on, you know, these are the types of very minor benefit changes that might be palatable in the relatively near future, if there are even enhancements on the table, which there will not always be.
And we could maybe not even see these in the next version of the budget. Okay, the last one on this list is funding related to administrative support of our agency request legislation around affordability. Kate spoke about this a little bit earlier. So this is just the administrative support that would be required to implement this bill. I do want to note that this administrative cost does come with hundreds of millions of savings for the program in claims costs. So while this does look like an increase, it is offset by a very significant claim savings. On the next slide, we're going to move into a couple additional things that were included within Governor Inslee's budget. The first one up is very technical in nature. It's about combining the PEB and the SEB programs for purposes of accounting only in the state systems. This is not tied in any way to our consolidation ledger report or the consolidation bill that Kate spoke to. This is technical behind the scenes for accounting purposes only. So currently, the PEB and the SEB program each have, let's say, 6 administrative accounts. Under this, you would have 12 administrative accounts where there are no monies being commingled, everything is still being tracked separately, but to ease budget and accounting issues that have happened over the last couple of years, this would just put everything in one program. So if any of you are familiar with reading some of the appropriation bills, where PEB and SEB are 2 separate sections within the appropriation bill, they will now be one, but we will still have each of our separate accounts within that section. So I'll take any questions on that, or Dave.
I'll just give a illustrative example of like how this might help some things. So the IT decision package that Tanya referred to had a split, but not a 50-50 split of the cost attributable at decision. Literally today in the accounting systems, people pull up 2 screens and have to code things twice. And there's the chance that maybe those numbers get flipped by accident, or maybe somebody puts in 50-50 instead, and literally having to change within program screens can cause the potential for human error. And so this streamlines things by just being able to literally see it all at once and say it once, kind of in a oversimplification of things. It's really technical in that way, and to help reduce the potential for accounting errors or fixes that need to happen in the accounting system statewide.
All right. Next up is something kind of exciting related to long-term disability. So our employer-paid long-term disability has the authority to be increased from $240 to $450 per month. The Standard, who is our vendor for our long-term disability, looked and did an actuarial analysis of our benefits, and it was determined that our employer premium towards LTD, which is approximately $2 a month, can go further. We can enhance the benefit within the existing funding that we have today. And it's really exciting that this version of the budget chose to enhance the benefit while maintaining the same employer contribution. Dave, anything on this one before I switch to the next screen because they're kind of related?
We've had a long journey talking about LTD over the recent years, and I think we're all very aware that $240 is the employer paid benefit. There is not a substantial payment, and that people were regularly surprised whenever they went to their benefits office and needed to move and out of more active employment and use this benefit to learn that the employer paid benefit resulted in such a small monthly allowance. Several years ago, there was a decision package that cost somewhere in the range of $20 million a year to try to enhance the benefit, and that wasn't picked up. Then this board took the agency's recommendation to shift the employee paid benefit to an opt-out structure instead of an opt-in structure. Many people retain that benefit, and or they're less surprised if they go to their benefits office and need to access this benefit. And this represents just another small incremental journey. I suspect many people would not be satisfied with a $450 benefit. That is not going to go that far, but it certainly goes further than $240. The last time that the employer-sponsored LTD benefit was changed was 2003. It was $180. Interesting bit of context brought up to me by Washington State University was back then the raise from $180 to $240 was to keep up with the pace of COBRA insurance monthly premiums. I'm pretty sure if anybody is familiar with COBRA rates, they're nowhere near $240 or $450, but that was the last time that there was an adjustment. And as Tanya said, it is appreciated that in Governor Inslee's budget that the being able to spend the same, essentially $2, continues on. Certainly another approach to this would be to maintain the $240 benefit and reduce that $2 contribution to whatever is necessary to retain the $240 benefit. If this change does go forward, we say likely, there would be some amount of a rate reduction on the employee paid benefits because for every dollar that's paid by the employer, that's kind of like the first level of coverage, and then the employee paid stacks on top of that. So by raising the ceiling on the employer paid benefit, then that has a premium differential that would come out of what the employees pay. And if this goes forward, we'll share what all of those changes will be as we go forward.
I was just going to say, maybe in future budget years when things are a little bit better, it would be interesting to tie that benefit to the COBRA rate, so it just automatically adjusts as COBRA changes. But not for now.
It was an interesting bit of context that I had never heard. And I was like, that got decoupled at some point. Here we are in 2025.
I think the year 1984 was mentioned in that conversation.
That's what I thought was the last time it was, and then I was corrected that it was 2020. It was 2003 was the last benefit change. Sorry, say that.
We weren't talking about Orwell.
No, we were not. No.
So I'm going to keep along those themes on the next slide here and keep talking about long-term disability on the employer paid side. For our long-term disability, both the employee and the employer paid side keep reserves. They keep separate reserves to fund those benefits. And because we have learned that our $2 contribution can go further than the $240 benefit, we've been accruing reserves within the standard for our employee funded benefit.
Employer paid. You said employee.
I meant employer. The employer funded benefit. So one of the things that Robin showed on her presentation this morning was a line item for PEB and SEB. That is directly tied back to these reserves. So the PEB employer paid reserves have about $18 million above and beyond what is required to keep in our reserve balances that can be withdrawn and directly deposited into the state general fund to help with the budget deficit. So that was the line item that Robin was presenting this morning. The other item that was included within Governor Inslee's version of the budget to address the budget deficit relates to the closure of the UMP Plus plans. So on our employee side, we have 2 UMP Plus plans with 2 different networks. We have the Puget Sound High Value Network and the UW Medicine Network. These are our value-based purchasing arrangements that have a financial contract that have upside and downside risk with these networks. And the Governor Inslee version of the budget proposes closing these plans at the end of plan year 2025. So at the end of the current plan year. Currently, we have contracts that are set to expire at the end of December 31st, 2026. So this version of the budget would have them closing a year earlier. I'm going to back up a little bit and talk about some of the evolution of these plans. When HCA first launched these plans back in 2016,
15 or 16.
15 or 16. They were really cool. They
2016.
16. They were super innovative. In fact, Washington State Healthcare Authority led the market here in our state for value-based purchasing arrangements. We actually partnered with some other very large employers within Washington State to help model their arrangements after ours. And we've really learned a lot over the last, can't do math, however many years this has been. Shortly after the launch of the contract, we had to do a pretty big change to some of the financial terms of the contract and make a pretty big course correction. And what you're seeing now is we need to do that again. We need another big change to this contract to keep up with some of how the market is going with value-based purchasing arrangement. We tried to do that. We tried to go out for reprocurement about a year and a half ago. That was unsuccessful. So we were unable to come to terms and extend or create a new contract with these UMP Plus plans. So what you're seeing here really is that at the time of Governor Inslee trying to balance a budget, there is money on the table that could be had by closing these plans and closing these plans early. So members based on this situation here would have to select another plan offering next year during open enrollment. However, because the UMP Plus network is a small subset of the overall UMP larger Regents network, members who chose to enroll in another UMP plan would be able to maintain their same provider relationship by picking one of those UMP plans. Another thing to note is that the cost of the UMP Plus premiums for 2025 has exceeded our UMP Classic plan. So you'll probably remember last spring, we had a lot of conversation around this. And the cost now is higher for UMP Plus than UMP Classic. I do acknowledge there are benefit adds to the UMP Plus plan that are more advantageous than UMP Classic, a lower deductible, no cost primary care visits, so that there is a advantage on the benefit side, but the premiums are now going over UMP Classic as a result of the cost of maintaining these plans. And I expect that would continue into the next year and so on.
And I'll highlight, it used to be before this year that if you signed up for UMP Plus, you had a lower premium and the enriched benefits. And now we're at a point where that calculus is a little different for people. And we saw several thousand individuals leave UMP Plus plans this year. And we think that a significant driver of that was this shift in premium from of UMP Plus that went over the benchmark plan. We had back on Alyssa's slides, it was about 5,200 individuals who left one of the UMP network. So there is a natural shift that is already happening within the PEB portfolio. We put on the slide and highlighted the provider relationship piece because one of the very first questions, if anyone hears the word closing of a plan, is will they be able to maintain their provider? This is unusual in the context of other conversations that have been had about various plans or service area changes. Here there is perfect overlap with the other UMP plans. So there is absolutely 100% overlap there, and being able to continue to see the provider by enrolling in another UMP plan. And by having just said what I did, I realized I want to go back to an answer that I gave to Harry a little while ago when I was giving some insights about the TPA expenditures, and I said there was a net increase of about 3,000 people into UMP. I had missed the lines on UMP Plus, and so it actually wasn't a net increase into UMP after this open enrollment. It was about a net decrease of about 2,300. So I'm sorry for misspeaking as I was just saying those numbers. I looked at it and I was like, I missed those lines whenever I was doing my quick math, which is why I shouldn't do quick math as a non-finance person in a meeting. So I just wanted to correct for the awareness that there wasn't a net increase across the portfolios in UMP after this OE, but there is still the true up of
From
changes from the last 2
2024.
years.
Yeah, correct. On the next slide are the funding rates that were included in Governor Inslee's version of the budget. I do want to say that these will change. These will not be the final funding rates. I bet my paycheck on it. We have another quarter worth of modeling that we will deliver to the legislature to consider for their versions of the budget, which will include another quarter worth of claims experience, the results of open enrollment switching, and some other various inputs that the legislature will use for informing their budget. Also, these funding rates include all of the things we just talked through. So they include the funding of decision packages, which may or may not be in the next version of the budget. They include the collective bargaining changes. They include the funding for our agency request legislation, which is actually a pretty significant decrease to these funding rates. And they also include the governor's budget deficit proposals that we just walked through. So the closure of the UMP Plus plans at the end of the year. So if all of that does not impact our funding rate.
That's right.
So if all of these items were to, continue on as is, and our modeling were to remain the same, these funding rates would probably, but they will not. So we will bring that back as we have more information, as we monitor the budgets throughout legislative session and we get to a final budget. I am happy to take questions now, or if you think of things later, feel free to send those on.
I'm going to make sure I'm understood. So it's a $40 increase between fiscal year 24 and 25.
Yes.
And that would, am I doing the logic math right? That would say with the 85-15 split, like the increase to the employee would be what, like $6 per month?
This is
Not that one. Okay.
No, we have to be really thoughtful about delinking the cost of benefits to the cost of the funding rate. So the funding rate here includes, a big chunk of it is the cost of the medical benefit, right? But what else is in the funding rate are things like our surplus or deficit position. So if we have reserves built up over this year that carry forward that can be used, that is something that both OFM and the legislature can do. If we have reserves, sometimes there's different approaches to and how they spend them, depending on how they want things to roll through the 4-year outlook. They can decide to spend them all down in that first year or split them 50-50. They could say, we want to hold all of your reserves. There could also be a situation where we're in a deficit from the prior period and they need to increase it to bring us out of that deficit position. There are things like admin spending that might not come in until the second year. For example, one thing I could give is the closure of the UMP Plus plans. The closure of the UMP Plus plans does have a shared savings arrangement that happens, but it doesn't happen as soon as you close the plan. There is a full reconciliation that happens well after the plan closure happens. So savings that are realized might not be until a future period. So there's things like that impact the funding rate at different times. But it's not necessarily a signal to say, oh my gosh, they're cutting benefits or they're raising benefits or anything like that. So this is largely trend assumptions that's causing the increase in the second year.
The other piece I think, Tanya, maybe to highlight, or I'll just say, you can correct me when I'm wrong, is in supplemental budgets, there's more information. This is all projections for the next 8 quarters. And so the full 2 years. But as we get this time next year, there's obviously 6 full months of the biennium that have been accounted for, and that's going into forecasts and beginning to ripple, and depending on those levers and directionality of that can, I think we could probably both bet our paychecks, but maybe I'll just bet mine instead of yours, that the second year always changes.
There's been one time that I can remember that that it has not changed, and that was during COVID because no one knew what was going to happen. And I have one last slide left. Yeah. Harry, I can take your question now.
Yeah, it's not really a question, it's just a comment. I've been around this board for longer than anybody else, I think. And the funding rate I can remember back in the days when it was in the 700s. So that's kind of where we are. It's not like it's not been stagnant. It's increased. So just a comment. Thanks.
I specifically remember the year it was $666. And it was not too long ago that we didn't want it to go above 1,000 even. And we were like, oh my gosh, it's going to creep above 1,000. So I'm with
I
you.
remember the 666. We were like, oh, that's bad.
I know. Can we get it $1 up or $1 down?
Seemed like a bad sign.
All right. So the next slide is just to wrap this up, which is just stating that the Medicare explicit subsidy remains at $183 in this version of the budget, or 50% of the premium, whichever is lesser, and that is maintained from calendar year 25, our current calendar year. And that's it.
Any additional questions for Tanya? Harry.
Yeah, thanks. Sorry, I'm a little unsteady today because I'm recovering from an illness, but so thanks for being patient. You know, my knee-jerk reaction when I saw these slides ahead of time was a lot of disappointment and frustration about what I was reading about the UMP Plus, because I was on the board when this was put into play, and you know, by definition, this is a high-value network, high-quality care, supposedly equaling better outcomes, better actuarial values. So to me, it was kind of counterintuitive. That would be costing more, but then staff and Tanya and Dave put it into perspective about the fact that the employee premium was above the UMP Classic. So that made me understand why we need to do this. But nevertheless, you know, we're still talking about 29,000 members who will have to do something. So, you know, just keep that in the back of our mind as we move towards December, that there will be a significant angst, and you know, to say, well, yeah, you still keep the same provider. I understand it, I get that, but it still ultimately means some action has to happen on the part of the member, whether it's going on to open enrollment, you know, in the 24/7 arena, or just double checking. But anyway, thanks for listening. Appreciate it.
Harry, I feel your pain. I helped build it, and to watch it go away is kind of sad, but I understand the leverage aspect of this has changed, the actuarial value, and the premiums just no longer support it. So to your point, communication, 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 I think we hear that.
And if this does end up in a final conference budget, and we talk about the process that the agency goes through for administering these types of changes, I do want to go ahead and give one piece of clarity is if a member doesn't engage, they would be automatically enrolled in a UMP plan. So they would not lose coverage in totality. People may want to engage, but similar to our transition to standalone vision coverage, we made clear what people would be enrolled in if they took no action, and a substantial number of people didn't take action, some because they missed the various communications, others because they understood what would happen and go, why would I sign into a system? What I want to happen is going to happen to my account. And Michael Duke here is pointing to himself as an example of somebody who understood that he was going to be auto-enrolled in MetLife Vision and didn't affirmatively then go take that action. So, but just wanted to confirm for everyone that the end result of a non-inaction in this type of situation would be being enrolled in coverage.
Tom.
Yeah, I have two questions. Could we go back to slide 8 for just a moment? So that TPA spending authority, increased spending authority to align with the increased self-insured enrollment and Part D transition. So is it my understanding, I want to make sure I'm correct on this, Regents is our third-party administrator for our medical, and MODA is our third-party administrator for our pharmacy. And is that correct, first of all?
That's correct.
And then does that 17.3 million, would that be going directly to MODA, or would some of that money go to Regents as well?
That's correct. It would be going to MODA and Regents because it's a combination of the increase fees associated with the Part D transition, as well as just regular enrollment increases within our uniform medical plans that would go to regions.
Okay, and then also could we go to slide 11 for just a minute? So I am assuming that the main driver in closing UMP plus is the budget constraints that we're facing. Is that correct?
I think I think one of the challenges that I think that exists for the PEB and SEP programs is they are not insulated from budget challenges like the state exists today. And at the same time, there are various constraints about how early and available certain changes are. So, you know, many changes that could happen within the program might cause the collective bargaining agreement to be reopened or impact bargaining to occur and, you know, some sort of agreement made. There are a lot of aspects to the program that have that type of effect. There are not many aspects of the program that don't run through something like the collective bargaining agreement or some other legal constraint. There are very few easy ways for someone trying to balance the state budget to leverage something out of these programs. Certainly not impossible, certainly not immune from the entire state budget process, but there are easier things and much less easy things to have the employer-sponsored insurance programs contribute to a grant solution. And this is one of those types of things that has both a very tangible cost that can be penciled out and is something that triggers less processes to implement from the constraints that I just described. And so in the context of the large 4-year outlook that is being looked at the state, I think this was something that people who were looking at the budget should go, well, this is a way for these programs to contribute. Let's put that on the table. Is that helpful context?
Yeah. Kind of picking up what Harry said also, there are 28,046 to be exact people that are going to be affected by this. My question is, so if they're not going to be affected by whoever their providers are, they're going to be able to get those no matter which plan that they would switch to, whether it's CDHP, Select, or Classic. But my question is, what are they going to lose? The people who are currently enrolled in Plus, what are they going to lose that would not be available to them in those other 3 plans?
I think it'll be helpful for us to bring that back in writing, but Tanya highlighted 2 of the key benefit differences. One is there's a slightly lower deductible compared to UMP Classic, and there is a way with the wellness incentive to get down to it being a $0 deductible plan. And then the other key benefit difference that many people are aware of and utilize is primary care visits have a $0 copayment or cost share under UMP Plus. And that's not the case. There is a co-insurance or co-payment, co-insurance, I believe, in the other UMP plans. And so I think it's going to be good for us to come back and highlight, pending where this is in the next budget proposals, to highlight some of those differences. We naturally thought first about the provider network piece. That is something that so many people hone in on. And as we've been giving this presentation in various formats, that the question that you just asked has come up quite a bit. And so I think that we are going to work on an iterative description about those benefit differences to make sure that people are aware of those. But the difference in deductible and primary care visit cost shares are 2 key parts.
Okay, thank you.
Any other questions for Tanya? Tanya, thanks so much. Appreciate it.
Thank you.
All right, next up, we're going to have a policy resolution. Stella Ng, our policy and rules coordinator in PERB, is going to be bringing us a resolution today to help clean up the retiree coverage outside the country. After Stella reviews the resolution with us, I'm going to ask for a motion to adopt. In a second, I will invite the public to comment on the resolution. We'll have discussion of the board until we're ready to vote, and then we will have a roll call vote. Materials behind tab number 7. Stella, welcome.
Good afternoon, Chair McDermott, members of the board. My name is Stella, Policy and Rules Coordinator for the PERB Division. Next slide, please. This slide and the next slide are included in the presentation, so you have them available as we discuss. Slide 4, please. We have one deferral policy resolution to be introduced and voted today. This is part of the cleanup as we implement Medicare Part D coverage for the UMP Classic Medicare plan. This proposed deferral policy addresses non-Medicare subscribers who permanently live in a location outside of the United States and become eligible for Medicare. After the introduction of the policy resolution, we will ask the board to take an action. Next slide, please. As a background, the board adopted resolution PEB 2024-26 last year that addresses Medicare retirees and survivors who permanently live outside of the United States. They may defer PEB retiree insurance coverage because they are not eligible to enroll in Medicare Part D coverage when they live abroad permanently. Next slide, please. We are bringing to the board the proposed resolution PEB 2025-01 to address non-Medicare retirees and survivors who live in a location outside of the United States on a permanent basis. When they become eligible for Medicare or when HCA becomes aware of the Medicare eligibility and they do not respond to HCA within the required timeframe, this proposed policy will allow HCA to automatically defer the PEB retiree insurance coverage. The reason is because subscribers who live abroad permanently will not be eligible to enroll in either Medicare Advantage or prescription drug plan or the UMP Classic Medicare plan as they do not meet the Part D eligibility requirement. Additionally, in terms of enrollment requirement and deferral process, we would treat these subscribers the same as Medicare retirees and survivors who are currently living outside of the United States. They will be exempt from the deferral form requirement and will have the opportunity to enroll in a PEB health plan when they return to the US. And the proposed resolution reads, proposed resolution PEB 2025-01, automatic deferral PEB retiree insurance coverage for subscribers who permanently live in a location outside of the United States and do not respond to HCA. Effective January 30th, retirees and survivors who are not on Medicare and enrolled in PEB retiree insurance coverage and permanently live outside of the United States become eligible for Medicare Parts A and B and do not respond to HCA within the required time frame will be automatically deferred from PEB retiree insurance coverage. These subscribers will be exempt from the deferral form requirement. Evidence of continuous enrollment in a qualified coverage is waived while a retiree or survivor enrolled in Medicare lives outside of the United States. A retiree or survivor enrolled in Medicare whose enrollment is deferred while permanently living outside of the United States will have the opportunity to enroll in a PEB health plan when they return to the United States by submitting the required forms and proof of enrollment in Medicare Parts A and B within the HCA required enrollment time. And are there any questions from the board before we let Chair McDermott?
I think you said it, but I just want to clarify. So when they return to the US, do they it's considered like a special enrollment period? They don't have to wait till open?
They don't have to wait till the annual open.
Other questions? Elliot.
I just want to make sure if I'm clear that you cannot be outside of the US more than 6 months and maintain your Medicare coverage. Is that correct?
That is correct for this scenario.
Yes, that's what I was referring to. Okay, I just wanted to make sure I understood that.
And Chairman Drew, just for complete clarity, these resolutions are so similar that sometimes reading them multiple times, you're like, what's the nuance? Last season, the board authorized the ability to defer, and this is the cleanup piece of, but if somebody doesn't respond, what happens to them? And for clarity, there's only two things that can happen to such an individual. They're either automatically deferred, as proposed in this resolution, or they removed forever from the PEB rolls and can't return. And so we presume, or I don't like to presume how the board will think, but I think I feel pretty safe. We're betting paychecks a lot today, Tanya, and now you have that stuck in my head that you would rather make a policy decision to allow them to come back if they return to the United States rather than eliminate their eligibility forevermore in the future. But I just wanted to put a really fine point on the only other option is remove them and their eligibility for the program, and that is not what is being proposed here.
I do wanted to follow up the comment that Elliot made about the 6 months enrollment. When they live outside of the United States, that's when someone who is enrolled in the UMP Classic Medicare plan and then they decided to move outside of the United States, they do have that 6 months period to continue in that enrollment. But for this particular resolution, it addressed the automatic deferral process.
Other questions? John?
Yeah, this is similar to a question I had last year. If this were to be the case and the retiree were to go on a spouse's policy when they went overseas, and let's say the spouse was working overseas for a year, could they take that break for a year and still be eligible to come back to this coverage?
So Stella, I think, correct me if I'm wrong, the posture of this scenario that's being addressed in the resolution the board took last year and the one before you today is about them permanently living outside the United States and recognizing that they may, or in most instances, won't generally have coverage under Medicare and can't qualify for these plans. And it's more about their residency than what coverage they do or don't have elsewhere in the world. One of the things that we talked about with the board last season was choosing to hook the return to the individual qualifying for Medicare A and B. And if the federal government says you're back in, then that's good enough for everyone. So that the healthcare authority here in Washington State doesn't have to learn the intricacies of every insurance market worldwide to determine comparability with plans offered in the state of Washington. And so there is, whether in your scenario somebody does have coverage through a spouse's employer that's international or has no coverage at all, or is part of a national health system in that country, this entire policy area is going, normally we would look at the comparability of insurance, require that you have insurance while you're out of the country. In this instance, for these individuals, if they come back to the United States, if CMS says that they come into Medicare A and B, that's good enough. And a reminder that the population we're talking about here that is accessing, that lives internationally is really small at this point. I believe it's not 3 digits, even in the totality of covered lives. Did I get anything wrong, Stella?
No.
Anything you need to refine? That was there's hesitation there.
No, I think you're right, and the number is really small.
Any further questions?
Thanks, David.
So we're getting ready for the vote. I'd like, yes.
I do wanted to call out, excuse me, the voting slide, the title, the word proposed should be strike through. Sorry about that.
Anybody on the board have an issue with not rereading the proposed resolution for expediency's sake? Seeing none. Is there a motion to adopt?
I so move.
Is there a second?
Second.
Any comments from the public?
So for clarity on process, because we're in our brand new world, if you are a member of the public who wants to provide public comments specific to this resolution, please raise your virtual hand and we will give you permissions temporarily to provide comment on this resolution.
Do we see anyone? All right, any comments from the board? This will be a roll call vote, starting with Elliot.
Usually I'm at the end with a W. I support this proposal.
All right, we're mixing things up today, Elliot. It's getting a little crazy.
Elliot starts with an E as the earliest alphabetical letter by first name. Sometimes we mix it up.
Okay.
They're not?
Nice try though. Michaela.
Yes.
Sharon.
Yes.
Her.
Yes.
Mary.
Aye, yes, affirmative.
That's only one vote though, right?
Only one vote.
John.
Jonathan.
Oh, I'm sorry. Tom.
Affirmative.
And Lou, affirmative. Resolution 25-2501 or 2025-01 passes. Stella, any final comments?
So the next step will be, we will amend standard retiree communications. We will update training materials for staff and incorporate this resolution into our rules. Thank you very much for your time.
Thank you. All right, next up, I think Dave's pinch hitting. Dave is going to be giving us the talk through the procurement benefit planning cycles for the PEB program, materials by tab number 8. And Kyla, thank you. Take care.
Right. All right. It's afternoon. Good afternoon, Chairman and members of the board. For the record, I do know my alphabet. My tracker is in alphabetical order, and the script is not in alphabetical order. So that's where I got confused. I am pinch hitting for John Parton, who was not able to be here today. But this is the part of the meeting at the retreat where we often are talking about the benefit design cycle, that process, and soliciting ideas for potential benefits enhancements. As has been previewed in other parts of the meeting, the end of that purpose of this presentation is a little bit different than the past. But we still wanted to talk about what the cyclical process is and a little bit of the refinements to it for this upcoming year. So on the next slide is just a reminder that there are a variety of ways in which benefit ideas, benefit design changes are brought to the agency's attention for consideration, evaluation, and assessment. We have here the board, the executive branch, various parts of the federal government, the legislature, our members, as well as our labor partners, and all of them ultimately have a funding question. That's why big banks are here. And we've previewed a little bit of some of the challenges in the near future for the financial aspects. So just a reminder of all the sources of those ideas. On the next slide, we talk about the contract renewal cycle. And in the appendix, I'm not going to walk through them this time, but in the appendix are 2 charts that talk about the cyclical nature of our work. One of my favorite lines to say for the programs is that every 12 months we have an 18-month cycle. Because it's just such a little bit of a cognitive dissonance there that we are doing the end of one cycle as we are beginning the start of the next cycle. And it's we're always talking several years out into the future. And so typically if we were talking about potential benefit ideas, now that would be teeing up things that could be implemented possibly as early as 2027 or 2028, depending on where things happen in the process. So, given the financial forecast of the state and how trying to manage expectations about what the next couple of years could look like, we wanted to kind of raise awareness about what's happening, the limited opportunities that there might be for enhancements, and the real possibility that there could be reductions in the benefits portfolio, though none of those have been kind of proposed to date. So as we talk about the benefit cycle on the next slide, we're going to be doing a more streamlined process than we have in the past because of the more limited scope and the potential for changes in the near future. We're going to be reviewing things, revisiting things that were reviewed in this cycle in the past. We're going to be looking at some of the proposals that have been accepted and implemented and look at utilization. And if they're lower than expected utilization, are there refinements, replacements, or even repeals of certain benefits that might be able to be part of a grander solution for the state. And then as we go through that analysis, if there are things that come up, we'll bring educational awareness here to the board and to the public. And again, as I highlighted earlier in answering one of the questions, is many benefit changes have a direct relationship to the collective bargaining agreement. And so there is a true acknowledgement of the implications there and the potential for bargaining discussions depending on the exact nature of anything that comes up. But the short version is that we're not going to be adding a lot of new things to the analysis. Some of the things that have been reviewed will just kind of be refreshed. And also, again, looking at things that have been recently implemented to see how the utilization panned out versus the projections when we were doing the original analysis. That's really all I wanted to bring on behalf of John related to this, because I didn't want to just have at the retreat nothing that acknowledged the benefit cycle. But normally we would transition to a brainstorm of things that people are interested in. But again, reinforce the state of the budget outlook and what's being worked on. Not going to ask for a brainstorm today. I'm happy to talk one-on-one with individuals about where things are on various benefit ideas. I think we all should be watching the legislative process on benefit bills. That's going to be the primary mechanism if there are changes beyond the small things that might be around the edges of the funding rate that Tanya described. And then happy to answer any questions about this process.
Any questions for Dave?
So, trying to figure out how to word this. Have talked to like a number of like supplemental benefit specialists, businesses that one thing they're offering, knowing that we're not the only employer that's in a situation like this, is something around the lines of, hey, if your employer is willing to kind of leverage this as the benefit they want to offer, and like what came to mind was something around like same day pay. That it was like, it would be no cost to the employer, but a reduced cost. Like if you like say, this is the one where we're putting our name behind, it's a reduced like cost to the employee to utilize the benefit. So still giving them access to something without a cost to the employer. Is that something that we'd consider at all?
I'm never going to say never. And I think some of it is what authority and exactly what benefit piece. I think it would be challenging, for example, if someone brought a plan that had been subject to procurement as like a medical plan offering, and then there's the limitations on the board's authority, which kind of relates to that PEB board authority agency request legislation to expand the potential authority for employee paid benefits. And that's kind of the space where I think what you've described, highlight, tends to come up. But even as it stands right now, without passage of the agency request legislation, or as Kate pointed out, it's embedded within the consolidation bill that is for the legislature. Without that, it would be there. I'm not sure that it would really depend on if the board even had authority to do that. The subboard might have authority with regards to some of those benefits, and that's kind of the purpose of that agency request legislation. So I think if something came today, it'd be really hard to get to yes under the current statutory framework. If one of those bills passed, it might be a little easier, not tomorrow, but the next cycle, if you will.
Okay, thanks.
Harry?
Yeah, hi, thank you. I know that smart health is not a huge budget item in the scope when you put it in the scale of the entire plan, but it just seems to me that it ought to be a consideration. I don't want to get a lot of rocks thrown at me, but it's a program that really is pretty anecdotal with regard to results from everything I can recall. And I know intuitively, people probably ought to have good outcomes if they practice all of the various opportunities presented and encouraged and coached by Smart Health. But I don't know if there's anything that said that anybody has missed being diagnosed with some sort of disease state because they participated in this and that they're actually getting better. So I'm just throwing that out there as something that I think that, might be something to review and just leave it at that. Thank you.
Thanks, Harry, for that comment. I think, the best proxy that I have is when the pandemic began, there were similar conversations about the state budget. People had lists, and wellness is always something that gets assessed. And so we'll just see where that conversation leads and if that comes up again.
Other questions for Dave? All right, why don't we go ahead and take a 10-minute break? We We'll reconvene at 2:05. Hey there, we're back. And next up, Missy Yates, Stakeholder Engagement Coordinator, and Herb is going to go over some results with us from a recent employee engagement survey. Missy's materials are behind tab number 9. Welcome.
Thank you, Chair McDermott, members of the board. For the record, my name is Missy Yates, and I'm the Stakeholder Engagement Coordinator for the Employee and Retirees Division, Benefits Division here at the HCA. I'm here to give you a summary of the results of our active employee engagement survey from June of 2024. So this survey, we designed it to serve sort of a baseline for any future surveys that we might do with the active employees, and also perhaps as a catalyst for future engagement opportunities with our active employees. PEB area. Next slide. To give you some background, we had a couple questions to determine subscriber status as far as whether they were PEB or SEB or a PEB employer group member. And then we had 18 questions related to the different types of satisfaction levels dealing with any of their benefits, medical, dental, vision, long-term disability, and even life insurance. We asked them questions about their satisfaction levels of out-of-pocket costs. We asked what they considered to be some of their most important considerations when they were picking benefits, when they were picking employers with the benefits, things like that. And then we had some open-ended questions as well. And then we also had 6 optional demographic questions that we asked just to kind of get a feel for what folks thought, what people would do when they were asked such questions. The survey was open for the entire month of June back in 2024. And we had over 5,000 responses across both PEB and SEB groups. And in the PEB program, that we had broke down to about 1,800, a little over 1,800 people responded from the PEB program. 1,700 of those were state agencies and higher ed employees, and 144 were PEB program employee groups, but which were like city, municipal, county, city, water district, those types of folks. So it was a really good response, we thought. And if you go to the next slide, we'll go over some key things, some key takeaways. Before I start that, is there any questions about the structure of the survey or anything about the background that's provided?
Any questions, board members? Think you're good to go?
So some key takeaways. We got a lot of information from members about their levels of satisfaction. We got a lot of comments on this survey, which was very helpful for us. So these next few slides are going to talk about some things we pulled out of there that'll help us, as I said, come up with better ways to communicate and engage with our members and consider as we continue to work on collaborating with them, with the BAs, with labor unions, and we also improve services for the employees themselves. Next slide. So in this slide, we asked 2 questions. The first one about benefits, we asked them, what are your top 3 benefits in terms of importance? When you were considering all the benefits that were being offered, what ones were the most important to you? And of course, the top 3 were medical, dental, and vision. Then we also asked, what are the top factors? What are your top 3 factors when you're choosing the current benefit or health plan enrollment that you have? What did you consider to be the most important to you? And those were costs, benefits, and coverage, and also provider network. And that included the provider choice, having the choice of which one, and that community, that continuity, being able to stay with their providers. So those were the top reasons that most of those folks in the area said they were most interested in. Next slide. So to give you some context of these pie charts, these go in kind of a clockwise order. I was very satisfied and satisfied being on the right side, and the dissatisfied and very dissatisfied being on the left side of each of these pie charts. When we asked members of what their satisfaction was in terms of medical, dental, and vision, you can see here that our PEB population felt they were pretty well satisfied with their medical and their dental, but the vision satisfaction rate kind of gets a little bit lower. They're mostly satisfied with about like about 50%, 30, 45, 46%, with that neutral 24%. So they're kind of in the middle there. It was very eye-opening to see that because you have medical and dental being very positively viewed with their vision insurance is something that people weren't rating as highly satisfied. Next slide. So in this one, we asked them their satisfaction for overall benefits as well as what they considered out-of-pocket costs compared to their benefits to receive. Nearly 3/4 of the PEB survey participants said they were satisfied or very satisfied with their overall benefits, while less than half the survey participants indicated that they were satisfied when they compared costs to the benefits received. Again, but slightly less satisfaction there. A large number of people were in that neutral area, kind of not positive or negative, just sort of in the middle on those decisions of whether they were satisfied with it or not. Any questions about any of those pie charts that I just showed you? Karen?
Darren, you're up.
Yes, thank you so much. And I appreciate that, Missy. So just a couple of questions in terms of the survey development. So the questions about choosing possible plans. I imagine there were 3 choices that were given to respondents. Is that the case? And then they had to choose around cost and what have you? Or did they develop their choices on their own?
Are you referring to the subscriber priorities?
So I'm going right back. I'm so sorry because perhaps I should have asked this earlier. Yeah, the subscriber priorities, the reasons for choosing current plans. There are 3 choices here. So were these choices given to respondents or did they just derive these on their own?
No, there was a variety of answers and choices they could choose from.
Yeah.
And these were the top 3 choices. I don't have it in front of me what all the choices were. Some of the other ones might have been, I can't really remember at this point, so I could get those for you if you would like to see what the other options were.
And so, no, I think that's fine. Thank you so much, Missy. And so then my other question is this, was there a write-in choice as well, or was it just all closed-ended that they had to select among?
Not at this point, but there were a couple options later to give us what they thought would help improve their levels of satisfaction and what they thought we could do to improve their benefits. So there are a couple places where they were able to write in comments, and I have some insight into that in later slides.
Excellent. And that's something that I'd certainly be interested in their write-in choices. I wasn't so sure if you had these open-ended choices on these instruments. So that I'm certainly looking forward to your findings on that. Thanks so much.
Yes, you're welcome. So the next slide, again, this is referencing some of those write-in comments that we had. We kind of pulled out some themes based on the comments we were seeing from those open-ended questions and identified some what we considered pain points for people based on comments where people made complaints or made comments that they weren't happy with some of these things. And you can see here a list. They're not in any particular order, but I did put the increasing costs and cost transparency at the top because that did come to the surface quite often. It was often commented on. Concerns about rising costs, of course, has always been a concern for our members, but also cost transparency, people talking about trying to figure out a way to figure out how much is something going to cost them before they go through a procedure and having difficulty figuring that out and being concerned that they don't know until they get the bill. So that comment came up quite a bit. So I left that at the top, but there's other information here that you'll see. Accessible information. That refers to everything from plain talk, being able to understand the terminology and jargon of healthcare, to being able to find information on carrier and HCA's websites easily. That includes having plan names that are similar, terminology that's similar in nature, such as co-pays and co-insurance, those types of things. People get confused with those types of things. And also just having the ability to, get to where they need to go within a couple clicks rather than having to search through and getting lost inside a website. as you can see through the list, if you would like me to point out or explain other ones, I would do that. But in the interest of time, I'd be happy to just go on to the next slide if you wish. So in the next slide, we also noticed that there was a lot of comments about whether people understood their benefits well enough. We did have a couple of questions about that. We first talked about whether people felt they had access to the information they need to make informed decisions about their enrollment before they enrolled in their plans. And you can see here, PEB members, they're highly rating that at about 76%. Responders responded at about 68% rating that they felt they understood their benefits. And then when we asked people if they agreed that they had access to plan choices that met their needs, only 62% agreed with that comment. And then when we asked if they agreed with the statement that using my benefits is easy, 63% answered in a positive manner for that. So we think that part of this, and that's including the comments that were brought up later about not having access to information or not understanding all of the information related to their benefits, has something to do with some of that. So that's something we're going to be considering as we move forward to communicate and engage with our members. Slide. This one was a fun one because we gave everyone this list of options of where do you go to find help when you need it, when you're trying to either enroll or you're just trying to find information about your benefits. Most overwhelmingly, I will say they were given the opportunity to pick up to 3 off of the list. The most overwhelmingly chosen spot was they contact the carriers. They contact their insurance plans to see if something's covered or to find out information about their plan. The second place that PEB members go is the HCA website. I think that's due to our BAs, our benefits administrators at the employers. They highly reference that. A lot of information is easily, readily available on our website. And I think the PEB population is used to going there to find information out about their benefits there. And then there's a little bit of a tie or a race here between the human resources and their healthcare providers on that third position. In the appendix, I do have a small list of what other is, and that was where they were able to write in other things that wasn't on this list. Here's some fun ones in there. Google being one of them, but there's some other ones in there too. So their sister or family members, things like that. So it's interesting to see how they interpreted the answers we provided as a list. We do have coworkers, friends, or family in there, but then they pointed out other people in the family. So it's interesting to see how people read the answers and then choose to write in something differently. But again, the insurance carriers are the ones they go to first. HCA is the second in this instance. Next slide. Then based on those comments, again, we pulled out and extrapolated some key themes of what subscribers seem to want out of their benefits, what they want. Most is, of course, lower costs and fees. Again, that accessible information, easy to find information, easy to understand information. Having access to educational opportunities. Again, that health literacy piece where people can get some help or some structured information that will help them learn more about how to utilize their benefits better. Navigating the website, navigation to the websites that they're using, either the carrier site or the employer site or HCA's website. In the area of more coverage or more benefits, there were comments about weight loss treatments, infertility treatments, increasing the vision benefit to be an annual rather than biannual, and also things like healthy lifestyle items like gym memberships or massage and naturopathy, things like that. And then another key area was process simplification. Again, it comes down to making it easier for the person to understand, making claims processing simpler, pre-authorizations and referrals, appeals, all those processes are complex and very difficult for members to understand, and they would like to see more simplification in those areas. Any questions about all that before we move on? Yes, Sharon, go ahead.
Thank you again, Missy. I think you've addressed the question that I had. However, I do want to pose it in any event. So this is slide 107, which is something that is of interest and at the same time concern. 25% or 24% really of responders that they don't have enrollment decisions. My question is this, as you dig deeper, or were you able to dig deeper? I know you mentioned processing claims, perhaps the structure of information. Were you able to identify what specifically that yielded um, inadequate understanding of the information among the 24%? We can get caught up in 76% because that's certainly the substantial number, but I do want to hear about 20%. Do you have any information?
Unfortunately, the questions, the way they were set up, they weren't close enough to each other to be able to correlate the 25 or 26% of people who were dissatisfied or disagreed with that statement to pinpoint their comments later on in those open-ended comments. But this again is one of those places where we could identify a group of people we could engage with and find out more information from them about their dissatisfaction with that or their need for more information and trying to be able to access the information before they make enrollment decisions.
Yeah, thank you so much. And it's not so much that they're dissatisfied, it's just that their feeling is that they're not able to access. And so there needs to be a way for understanding what it is about the system where the information is presented and distributed that do not allow them to fully understand. 4% is a substantial number. So my thought is to understand that group. The other issues around slide 106. You indicated that increasing costs and transparency. Well, certainly the top three items are increasing costs, accessible information, and prescription coverage. My question is this: to what extent have these three items have been consistent over we see this for this year? Has this been the case for, say, the year prior, or even the last 3 years, that these items have yielded, certainly have become the top three items that you identified?
Interesting that you say that. This is actually our first survey to the group regarding these types of questions. We have engaged the retirees for quite a while now, as you may know, but this is our first active employee engagement survey that we've done like this. We've done some communication surveys in the past, but this is really our first one where we've asked these types of questions in the recent years, at least that I'm aware of. So we don't have anything to compare it to. This is our baseline.
Yeah, that's something that I'd like to see a trend for. If there's any improvement over time. I know that you guys have been working certainly on the cost piece and the transparency. And so that's something that I'd love to see next year what the outcome is. But my initial thought, or at least my initial query around understanding that 24% who lack the literacy to navigate the information that's presented. That's something that I think could be important for us to dig deeply into to see what can be changed in terms of information delivery. Thanks so much, Missy.
Thank you, Sharon, for your comments. All right, and lastly, our demographic voluntary response. Again, these questions were at the end of the survey, they were completely voluntary and completely anonymous. As you recall, last year I did a presentation regarding a project that we're working on for our Benefits 24/7 system for collecting race, ethnicity, and language data for our PEB and SEB members. And we are working on that project. We've done a lot of community engagement over the summertime with a lot of different groups, employee resource groups, different agencies across the state to talk to various members to find out more information and build a questionnaire to put into Benefits 24/7. But as you heard earlier, Benefits 24/7 is still working through stabilization, and that is the priority. So while we're working through that, we figured we would do this short, minimized sort of set of questions in this survey, just to get a feel for how our members respond, to see what the response rate would be, and if we would have any, interesting insights into what members feel about answering such questions. So if you look at the next slide, these were the 5 questions that we asked. We also asked an age question, which was a ranged question I didn't include in this one. But this was, we asked these, and these are going to be questions that we'll be asking on our Benefits 24/7 questionnaire as well. And you can see as it progresses across the hesitancy, I will say, for people to not want to answer the question. These percentages are percentages of people who either chose not to answer or answered not applicable to the question when we were asked what their preferred language was, what their race and ethnicity, how they identify their race and ethnicity, their sex assigned at birth, gender identity, and sexual orientation. So I think this gives us some insight into members' participation into our future demographic questions, gives us more to consider as far as what rates of participation we may have, and it gives us some things to consider as we move forward with our other project in light of all of the sensitivity of these questions. Are there any other questions?
Do you have any questions for Missy? Missy, thank you so much. Appreciate your time today.
Thank you.
Laura in person. Hey, Laura. We got Laura Ryan here. She's the retiree benefits manager in PERB and is going to give us an update regarding retirees and the PEB program and continued engagement efforts with the retiree population. Materials behind tab number 10. Welcome.
Thank you. Good afternoon, Chair McDermott, members of the board. My name is Laura Ryan, and I am the new retiree benefits manager here to present Medicare updates. So here's just an overview of what we're going to discuss today. I'll just give a brief introduction to myself, go over the open enrollment Medicare plan changes, a recap of benefits fairs this year or this past year, and some planned communication improvements that we have. So first, just to introduce myself, I am new to this position as of the middle of September. I came to this position from SHEBA, which is in the Office of Insurance Commissioner. When I was there for several years, assisting Medicare enrollees, I mentored some of our volunteers there and handled things like escalated Medicare-related requests. Prior to that, I was actually here at the HCA. I worked in the PEB Retiree Customer Service Division for a couple of years. So I have a lot of experience working with retirees, processing forms, enrollment questions, things like that. And then prior to that, I actually worked in the kidney care arena. I worked for a company called PEBB. Most people who have end-stage renal disease are on Medicare. So that was about 8 years of various Medicare-related experience there. And then I had the great pleasure to have a 3-month crossover with Ellen Wolfhagen. She was able to hand off a lot of things to me during that 3 months, where I have spoken to some of those of you on the board, managing our PEB Medicare inbox, handling the UMP question inbox, and I was also able to attend several of our benefits fairs. So moving on, we will begin looking at some of the switching data from our past open enrollment period. This first table here is a representation of members in the retiree program who do not have Medicare. So you'll see how many were enrolled pre-open enrollment, post-open enrollment, and then the change. And you'll notice that enrollment has gone down in all of these plans, and that's simply due to these are members who are aging into Medicare. And then the next graph here is showing retirees who do have Medicare and what the numbers look like pre-open enrollment, post-open enrollment, and the change. So you may notice that the Plan F enrollment is down, and that is simply due to members who may have returned to work, passed away, or are simply no longer enrolled in that plan.
And Laura, just a reminder for the board that there is no future enrollment in Plan F that's permitted, so that number can never increase.
And then our next slide is just a different way of kind of looking at the data that we just discussed of the switching that took place between 2024 and 2025. Did you have anything you wanted to add? Okay. So now we're going to just look at each plan, starting with the Kaiser plans. There was a service area change for Kaiser Washington Classic Medicare. This mostly affected Eastern Washington counties. About 2,600 members needed to change their plan. And these were members who were already seeing providers that are included in at least one other plan's network. So they did receive extensive communication from both the HCA and Kaiser to inform and guide them through those changes. Next is the Premera Medicare Supplement Plan G. This does continue to be a popular option with growing enrollment. As Dave discussed, the Plan F is closed to new enrollees and re-enrollees. The Premera presentations at the benefits fairs were very popular this year. And we also had Shiva support at the benefits fairs, which was very helpful for members who might be interested in this type of a plan and might have questions about how to enroll in the commercial Part D plans. And then the UMP Classic Medicare with Part D. We've received a lot of positive feedback regarding the reduction in premium costs. And there has been a general acceptance of the change to a Part D. And again, we did send extensive communications regarding that Part D implementation. And as has been discussed in some of the earlier presentations, we have had some technical challenges with our system files. So one thing to note is plans do go through a CMS approval before they are implemented. So we've had a little bit of a disorder with certain enrollment changes going to CMS out of order. Essentially, CMS was not receiving a cancellation from a previous plan before it was receiving the enrollment in a new plan. So that has resulted in some of these challenges that some members have had where they're expecting an enrollment specifically in the UHC plan, but they might still be in a little bit of a loop with their old plan. So these are the issues that we're currently addressing. And then with the UHC plan, just a note on this is that it does continue to be a popular option. The UHC and the Plan F were our two plans that saw enrollment increases this year. With UHC, as we saw on the previous slide, the complete plan had an increase of about 2,839 enrollments. The balance plan had an increase of about 43. And a recap of our benefits fairs this past fall. We do find that retirees continue to be the main population at these fairs, and we found that the first half of the day is typically the busiest with retiree interest and questions. And as I said previously, the Shiva presence was widely appreciated at the fairs. We got a lot of positive feedback about them there. And in response to requests to have more comprehensive retiree materials available for handout at future benefits fairs, we are preparing some changes for 2025. And sort of leading into that, just a brief discussion of some communication improvements. So based on previous feedback we've received regarding retirees receiving too much information and the need to simplify, last year, our communication team did implement retiree-specific newsletters with a redesigned format for 2024. They also implemented a retiree-specific open enrollment webpage on the HCA website. And as of this year, we have convened an internal work group to identify and provide some simple communication resources tailored to specific retiree groups. So these groups may be current retirees, prospective retirees, retirees with Medicare, retirees without Medicare, Essentially, we want to have some communications that speak to a specific group so that they are not inundated with every possible scenario that may not apply to them. And the communications goal is to get retirees the right info in the right format at the right time. Another improvement has been in the past year, HCA also hired a new communications consultant who will be focusing specifically on the retiree communications. And that concludes my presentation. Any questions?
Laura, thank you so much. Appreciate it.
All right, thank you.
Dave, why don't you give us a preview of the sport season?
All right. I'd like to remind people about just the general story arc of board season. So March, we skip the month of February and allow a lot of the legislative process to be working itself out, so that we can kind of refine what we're describing about bills that are happening in the legislature. We probably are unlikely to have any new budget release before the next board meeting, but March and April is really a lot of time for policy decisions and the evaluation of resolutions that the board might need to act on. So that's usually the hallmark of the March-April area. The agency begins the renewal procurement process with the existing carriers in the early part of spring. And so then as we get into months like May and June, we'll begin having more executive sessions with the board to talk about kind of where things stand in the procurement renewal process. And then the June, July area is where we have the public presentation of premiums for the 2026 plan year and the premiums that are associated with that for the board to take action on. So just kind of reminder about the general story arc. Now, the interesting part or different part of this year is remembering that legislative session goes through April 27th, and then there will be actions that could require quicker implementation or taken into account in the late spring area for those rates, depending on what exactly is in the final conference budget. Some things might impact 2026, so things could impact future years, but there'll be a lot of quick response based on how the legislative session ends for these programs. So just a general reminder.
Tom?
Yeah, Dave, in Kate's presentation, he talked about one of the proposals was to ensure access, and that reminded me of something that you talked about. I think maybe it was June or even our last meeting or two. And I noted one of the letters that we received in the correspondence was about Virginia Mason leaving, or United Healthcare not working with Virginia Mason. That particular issue has come up not necessarily with United Healthcare. I remember last year you had trouble with Optum in a negotiation process. Anyway, I believe you had talked about some type of contracted negotiations which would ensure that people would not leave. That was something that you were going to consider doing. Is that something that's still on the table, or am I misinterpreting that?
Couple of pieces to unpack and respond to your question, Tom. Just I want to assure people that correspondence that the board received, the rolled up correspondence since the last board meeting, included some constituent requests related to what was one of those public provider network disputes and termination letters that went out, but ultimately Virginia Mason and United Healthcare reached an agreement and there was no network disruption. That was something I highlighted earlier today during the panel, that the vast majority of time, even when public notice goes out about a potential termination, although not guaranteed, the vast majority of time an agreement ultimately is reached. And so in that particular scenario for that one that was occurring near the end of 2024, that was one that ultimately reached resolution. And again, there was no disruption. Reaching back to the other part of your question, this morning I highlighted that there's a regular cadence where the various carriers and TPA advise HCA of kind of the status of some of the larger negotiations that are going on at any given time as they're staggered throughout the year. And that staggering throughout the year is something that I continue to push on the carriers to work to frame shift as much as possible negotiations that could spill into Q4. So that October, November, December, AKA annual open enrollment process for most employers that have a calendar year plans open enrollment, recognizing that some of the most, it's always a stressful situation, but it's even more stressful and challenging for those public disputes to happen while individuals are making plan changes for the next year. So that is something that's always a pressure on trying to have carriers work, but it does require an agreement between the two contracting parties to move things into different parts of the year. So that is something that's part of the general conversation all the time. Another factor that relates to this question is the agency request legislation. That is the reference-based pricing affordability bill. Part of that legislation would require the various hospital systems, if there's a good faith offer to them, that they would be required to accept that offer, and that could fundamentally minimize the ability for a large-scale disruption within the UMP, at least. Or actually, the bill applies to the entire portfolio. So within the various parts of the medical plan, it might minimize the ability for there to be that kind of contract dispute. So that's another factor that's in play. And then there may be other bills in the legislature that are trying to address different parts of the provider contracting process.
But what you just finished was what I was specifically thinking of.
Oh, okay. So that concept is incorporated within the agency request legislation, affordability reference-based pricing bill. That first one on Kate's list on the agency request legislation slide. I just can't remember the bill number. I think it's 5083/1123. So House Bill
1123.
Senate Bill 5083.
Okay, thank you.
Other questions for Dave? All right, we're moving to public comment. We're going to go ahead and see if anybody wants to make any comments by raising your Zoom hand. And then we have the ability on our end to make it so you can turn on your camera and your mic. Do we have anybody interested in addressing the board? Kathleen?
I'm obviously not Kathleen. It's her user Zoom account.
Oh, okay.
Thank you, Chair McDermott. I appreciate the opportunity to speak to the board. My name is Matt Grosjean, not Kathleen, and I'm chair of the Healthcare Work Group of the Retired Public Employees Council of Washington, but I am speaking today as an individual. First of all, I want to thank HCA profusely for HB 1123 and the Senate bill related to it and your advocacy for reference-based pricing. This is an important bill towards lowering the cost of healthcare. I also greatly appreciate the increased level of engagement with PEB retirees. Secondly, I'm a member of PEB Complete. The benefits as listed in the EOC are excellent, and I want to thank PEB for negotiating this plan. However, from my very first call to the plan in 2022, poorly trained United Healthcare customer service agents have consistently given me blatantly false information. It was an unwelcome shock after the highly professional service I got from Regents for UMP Classic Medicare. I doubt my negative experiences are atypical. I am therefore here today to urge PEB to conduct a written survey and listening sessions with PEB Balance and PEB Complete members on their customer service experiences, and if indicated, intervene with UHC and contractually require that subscribers receive accurate information from customer service agents about their plans and benefits. This would include enforceable quantitative measures with potential financial penalties over and above the current CAPS requirements. These following interactions are based on my direct personal experience as an informed consumer who surprisingly reads the EOC from cover to cover. What is happening to those who are not? One, on my first call to UHC in 2022, I was told the plan covers orthotics. It does not. Two, it took me 3 calls over 6 weeks to get the 2023 EOC mailed to me. 3, a representative later told me, even after checking with her supervisor when I questioned her on it, that massage therapy was covered by PEB Complete only for, quote, Medicare approved massage therapists. That's an oxymoron. On another call, I was told claims would be sending me a letter on how to submit a receipt I mistakenly excluded from an online claim submission, and that my wife would receive partial payment for the 2 receipts that I did submit correctly. No letter or partial payment was received. It was resolved only after my wife left a negative comment in a phone survey, which most people won't do. 5, I called Optum in December to confirm the 2025 cost of a Tier 3 drug for which I had received Tier 2 step therapy approval. I was told it would be something around $251.50. I'm not sure the exact amount, but this is obviously false since PEB Complete drug pricing is via copay and not coinsurance. I later received the drug and the cost was $200. Finally, my wife received an 8-page UHC questionnaire from her chiropractor's office. The office said completion of the questionnaire was required for them to get payment. The form included, and I'm not joking here, questions about her mental health and her sex life for chiropractic care. We called customer service twice and were told both times that the form was indeed required. We then emailed Martha Melosi, the UHC senior account manager, who after a number of back and forth emails, eventually told us we did not have to submit the form. My suspicion is that it's required only for subscribers to UHC commercial market Medicare Advantage plans, and they mistakenly included PEB Complete. So if this is happening to me, a reasonably informed consumer, imagine the level of potentially harmful information given to other members of the plan, resulting in lost time, money, and access to the crucial healthcare benefits guaranteed to them in the contract. Please act now so that when UHC members call, they are given accurate answers to their questions by competent, well-trained staff familiar with the 2 PEB plans. Thank you.
Appreciate your comments. Thank you, sir. Next. All right. Not seeing any other individuals requesting to comment. Our next meeting is going to be held on March 13th, 2025, starting at 9 a.m. We're going to have the same format as we do today. Dave, any final comments before we adjourn?
All right, can we get to my mute button in real life? Just wanted to highlight that at our next meeting, we'll have a further update from Cade on the legislative developments on various bills. As I said, policy and rules development, there are pieces to bring to the board to begin teeing up for possible action at the April board meeting. We'd bring that first in March. I appreciate your willingness to act on the urgency of the one Medicare Part D piece that we were brought to you today. Continue to have updates to the board about stabilization of benefits 24/7, and then anticipate that we will have one more piece to talk about with open enrollment, which is what do the appeals look like? We usually don't see a lot of the appeals volume from open enrollment by mid-January. That usually happens more in the month of February, late January, February. So it's always another indicator as to how open enrollment went, what the appeals volume is. So I anticipate that as another presentation. So just a few of the things that, oh, and the prior authorization, working on a presentation about prior authorization questions that have been brought up, and the implementation of House Bill 1357 that passed last year.
Any questions or comments from the board? All right, Dave, thank you to you and your staff. Michael, thanks for the AG's office. Really appreciate today's meeting, and our board members, of course, for attending. It is a long meeting, but everyone's attendance is really appreciated. Dave, thank you to your staff for the updated Zoom procedure we're doing. I don't know what we're calling it, but we're just going to stay up.
Zoom webinar
To make sure that this meeting goes smoothly without disruption. So thank you so much. This meeting is adjourned.